So, webcast, is it up and running? Or do you need to start it? Okay, thank you. Morning, everyone, and welcome to the Health and Adult Social Care Select Committee. We will rattle on because we're starting a little late this morning. So, first agenda item is welcome and update. So, just to update members on a couple of items. You'll find within your agenda pack, we've had a response from the NHS Trust. I'd like to thank members who gave some fantastic input into the HASC response to the quality account. And we've had a follow-up statement from the NHS, which has clarified points on a couple of questions that we had. So hopefully that's been of use to members. And in a similar vein, next item, Oxford Health Mental Health Trust came to a HASC, and we followed up with quite a few questions, and again they've responded and given us a thorough update with further clarification points. Third whammy, dental services as well, they've done the same, so hopefully that's been informative for members. There is an agenda item to update you on which is not on the paperwork. So members will know that there has been some discussion, ongoing discussion, particularly Councillor Stutchbury and Councillor Mordew will know there's been ongoing discussions about the SWAN practice in the north of the county. SWAN practice is made up of 3 GP surgeries. Many of their offices and practice locations are no longer fit for purpose, and they have been struggling with difficult surgery locations, and there have been ongoing discussions. Well, I'm pleased to say that the practice is about to enter into a 12-week consultation period at the beginning of August. We're still waiting for a start date, but they are promising us a very strong and robust consultation. They want to hear from all stakeholders. They will supply us details of the consultation, and it would be wonderful if all members of this committee and of council in general can help to share that with residents and interested parties. So I know I had a discussion with Councillor Stutchbury and Councillor Mordew yesterday, because it does impact on them because it sits within their ward area as well. I think the HASC had a scenario with the Long Crendon practice where we had grave concerns over the consultation process. So I think this is a very positive step forward. There seems to be a very robust process being put in place. An equalities impact assessment document is being prepared, and there will be plenty of material for the HASC to scrutinise, and hopefully we'll get some very strong recommendations of how the practice is going to move forward and improve provision for local residents in that part of Buckinghamshire. So we did have a chat, didn't we, Robin? I can see your hand going up straight away, and I think the discussion we had yesterday, I think all 3 of us felt there was some follow-up questions, some clarification points that you'd like us to put forward. Robin, I don't know if you want to start, if there are some specific items.
Firstly, thank you, Chairman, for the positive update. I think we need to see the impact assessment. I think we need to assess what that is. I think we need to realise that this is been a long time coming, and the fragility and nervousness around it in the community because it's been so long coming. So we need to get some surety of what they're intending to do. I think, as Councillor Mordew said yesterday, I think there are some fragility around the planning issues on it which we need to investigate, and we also need to be assured that the consultation with the public and what they're consulting about, because there's been many things said now, and the clarity around this project is from 2018 to here. I'm really pleased, Chairman, the quality impact assessment is going to be completed, because I took it to a previous chairman asking for it to be undertaken in 2018. So I'm really pleased it's moved forward now. But I am grateful, and I think the real questions are going to be, Chairman, as I said, we need to see what the consultation is, and I know Councillor Mordew, from our discussions yesterday, got some other concerns around it. Though pleased, I'm very nervous that this actually happens. Thank you.
Thank you, Robin. Councillor Mordew, do you want to come in?
Thank you, Chairman. I've followed this project since 2009, which is how long it's been going on. And planning took a long time, and planning was eventually gained by writing to Secretary of State for non-determination, and planning is about to run out in December of this year, which means that they will have to reapply for permission. I see it as another delaying exercise, and I can't see it any other way, because there has been consultations, admittedly not a public consultation, but there has been in-depth consultations about what should be provided at the facility. They have decided not to take any of those into account and start on a new public consultation. I only hope that they will actually come to an end with that and actually go forward. What I'd like to see is what timeline they actually intend to use, and bearing in mind that the planning permission will cease in December, and also how they're going to finance it, because the financing was in place at one time. In fact, if you go back to the original Schedule 106 agreement, £177,000 was allocated in lieu of rent to the Buckinghamshire Authority. There's been all sorts of funding pots. There's been various times when the other empowerers or stakeholders were going to offer services at the clinic, such as renal care, the accident and emergency unit, or primarily the accident unit, which was at Buckingham Hospital, may well come back. However, that is in abeyance now. I just see it as another delaying exercise, and I hope it's not. One of the problems is that we all know that the CCG, or the successor, the Bobs, doesn't actually commission buildings. They commission services. And unfortunately, I just see this as an NHS means of delaying it. For what reason, I do not know. But they will have to reapply for a new planning application unless they start before December, whatever the date that is.
Thank you.
There's additional
Howard.
concern. In the pre-consultation, as Councillor Mordew's quite rightly worried about this being a delaying tactic, and I support his concerns. But there was consultation, an impression given to the community that there was going to be a facility kept within the town centre. There was a discussion which presumably took place, which I was not party of or involved in, where they said they were going to put some facility within the library, within the one estate. There's never been any paperwork produced for that. There's never any, so there's lots of ambiguity around this. And this has gone on long enough, and Buckingham's community is growing greatly, and let's hope that this is a proper going at it and we're going to happen. But I do share Councillor Mordew's concerns. He and I have been around Buckingham a very long time now together and look at these things. And this project has had 2 public consultation meetings with the public in the past of various success or not success. So this consultation has to work, it has to be accurate, it has to be real, and it has to say what it's going to do on the tin. Because what we can't afford, Chairman, is to be sent round the figure of 8 again. And as Councillor Mordew said, the planning is tenuous, and he's quite right, and the situation could fall away from us, and we're not entirely sure about the resources of it. So any information around the resources in this would be really great for the Police Chairman. I know we had a really conversation yesterday. We've got a long meeting, but those issues that Councillor Mordew raised and I've raised are key to this. It's about the public, not us, and I'm not sure we're there yet.
Okay, lovely. Yes, so I take all that on board. So members know I did have a chat with Robin and Howard yesterday, and there are 5 or 6 questions around timelines, process, exactly what will be included in the consultation, what the proposal is for the new practice. So if members are happy to delegate to myself and Liz, our support officer, we will pick that up on Monday and actually write to CCG and the practice manager, and also to Neil Phillips, who's handling the comms around the consultation, just to get some further clarification on some of those details, so that we can be sure that this is a robust consultation and it's going to have a meaningful end result that's going to result in some forward movement on the practice. So are members happy for us to progress that in that way? Okay, thank you. Excellent. Right, move on. So that brings us to item number 2, which is appointment of vice chair. It is within my power, such heady powers, to appoint a vice chair. It's all very exciting. So I'm pleased to say, unfortunately, he can't be here today because he is taking a well-earned break. But Councillor Mike Collins has agreed to stay on as vice chair for the second year to give us a little continuity because we have several new members, and as everyone gets up to speed, and we can review that at some point in the future. So Mike will continue as vice chair. Item number 3, Kelly, apologies for absence.
We've received apologies from councillors Patricia Birchley, Mike Collins, Tony Green and Zoe McIntosh from Health Watch.
Thanks, Kelly. And Kelly is giving us some support today because Liz is actually on vacation this week. So we hope she's having fun. And obviously we've got Chris with us as well, giving us some support. Item number 5, minutes of the previous meetings. So we have 2 sets of minutes. One is from the last meeting of the HASC, which was held on the 4th of March. And I think I worked out earlier, I think Councillor Walsh and I are probably the only members who were present at that meeting. So are you happy to agree those? Thanks, Liz. And then 26th of May, of course, was the annual council meeting. We have our regular game of whack-a-mole where we choose chairs of each of the committees before they then go on to populate committees. So if members are happy, it's an accurate record, and I was selected as chair. So item number 6. So we are very lucky today to have Dr. James Kent with us. Thank you very much. I know you've got a very busy week, James, and you have rejigged a few things to be with us today. It's nice to see you. And he's going to talk to us today about the integrated care system. So over to you, James.
Thank you, Chair, and apologies I was just a few minutes late getting here, but pleasure to be here. I thought I did send some slides over that just give an outline. They're actually NHS England slides that gave an outline of what integrated care systems are expected to do, the ambition for the integrated care system. And so what I thought I would do is just give just 2 or 3 minutes of overview without using the slides to allow for Q&A, which I suspect would be the more helpful way of proceeding. So a couple of points I just wanted to make on opening. The first is that the move towards integrated care systems is a continuation of a direction of travel that the health system has been on for the past several years, starting with what was termed the 5-year forward view. We have been doing system working through STPs and ICSs as non-statutory bodies for the last 2 or 3 years, and what this set of proposals do is to effectively create integrated care systems as statutory bodies. I think there's a strong desire to move at pace, and I think that is partly because of the evidence, particularly through the pandemic, that joint working actually does lead to more efficient service delivery, but actually also leads to better outcomes for patients. And I think we've seen that in the way that we've moved through on the vaccination programme, which has very much been a joint effort, as well as some of the way we've managed PPE and mutual aid through the pandemic. So the direction of travel is an extension or acceleration of the direction of travel that we've been on for a while. At one level, the request is for integrated care systems to improve health as well as health outcomes, focusing on inequalities, improve productivity, reduce unwarranted variation, as well as act as social and economic support social and economic development. I think those at one level is laudable. If I then say why do integrated care systems are likely to address those more than the current system, it is because the new system will take out some of the competitive nature of the internal market and therefore allow for greater collaboration, and the structure and governance of the integrated care system is linked much more closely with local authorities that therefore allow joined up working, particularly on the inequalities and on the wider determinants of health. It also will allow that lack of competition will allow us to, and the increased collaboration will allow us the opportunity to do more integrated care where we are focused on whole pathways as opposed to individual providers of pieces of the pathway. And certainly the international evidence shows that there is that way of working is on the whole better for patients. It certainly allows the move to put more focus in on prevention, and it improves quality. It is less clear that that necessarily reduces cost, but it does certainly improves the value because the quality rises. What the paper shows is there is work in terms of a design framework that has come out that gives a lot of detail, or at least a detailed scaffold of how this system should be run. It talks about the ICS partnership, it talks about an ICS body, it talks about the importance of place. What we are currently in the process of doing is working up the detailed plans that fit locally for us around that scaffold. We are being given increasing amounts of guidance from NHS England as to how to fill that scaffold in. And I was told a few weeks ago there are 39 pieces of guidance in preparation. Each one, by the way, normally comes down with about 40 pages. So there's effectively quite a bit of work that we need to try and do with a view that we can have this system up and running by April of next year. In parallel, obviously, that requires legislation to go through Parliament, which, as members will know, isn't always necessarily as straightforward. But at the moment, that is our current plan. If I just talk about a little bit around what we are currently doing, and then I'll pause. The first is there are pieces of what we need to do that is actually relatively straightforward. So we do need to effectively take our 3 CCGs and the statutory functions that they exercise and move those across into one single organisation, and work is underway to make sure there is safe transfer of those existing functions. The second piece is we are working with some external support on understanding the options around how a place delegation will work. So in other words, how will the funding go down into place, and what is the right path to take to build either joint committees or provider collaboratives or other mechanisms whereby we can basically delegate funding down into place. So that is not a straightforward piece of work, but we are sort of halfway through that. That should read out towards the end of September. In parallel, we also have some external support by a company, the Good Governance Institute, that's also working with the region and with other integrated care systems to work our way through the governance, including how the ICS partnership will work and the ICS body will work, as well as the governance at place, which in part depends on how we're going to delegate down into place. So I'm afraid that what I don't have today is a detailed set of plans and proposals, but I'm very happy to talk through at least how we are trying to generate those detailed plans and proposals and the engagement that goes around that. So, Chair, let me just pause there, but very happy to try and take any questions, and I'll be clear what I know and what I don't know.
Thank you, James. Councillor Stutchbury.
Firstly, thank you. Read it. What I can't understand is how the legal skeleton to prepare this will work. I mean, of all organisations. Secondly, I'm not sure how what they call Project Keep with all the organisations will work. And lastly, I haven't seen any mention of new resource to support the change. The 3 important questions, because everybody works within a separate thing. If you're working together, you really need to understand that. I can't see where that's in it. Please explain.
Apologies, Councillor. I heard the last question about new resources. I didn't quite hear.
I'm quite happy to do it again. I don't understand the legal skeleton which supports this in the sense of the legal framework of everybody else.
Yeah.
I don't understand where you've put in what I call budget keep, is when different organisations have a resource, how they're going to pool it. And the last question was the resources, which you heard.
Yeah, very good. So the legal framework for this is held within the bill that's had its second reading in Parliament a week or two back. So there is we are working in parallel on form, function, and legislation. I think is the way to do it. So the way to articulate it, and so the legal form and therefore the statutory basis will effectively be enacted through the bill, which is due, I think, for royal assent somewhere in the February-March timeframe before we go live in April. In terms of your budget keep, if I understand the question correctly, then you're right. At the moment, the funding would come central for the 3 different places within the system would come centrally into the ICS. That then needs to get delegated down into place, and what we are trying to work our way through, which is the external support we've got, is how does that delegation work? So it could work, as you can see in the papers, it could go down to an individual place lead, so it could go to a person, it could go down to joint committees, it could go down to provider collaboratives, and that is that's the piece of work that we're currently undertaking. Your third question, are there additional resources? We actually at this stage don't have a budget for the second half of this year, and therefore we certainly don't have a budget for the April 22-23. We can all have our views of whether there'll be additional resources in those budgets.
Did you have a follow-up, Rob?
Yeah, thank you. Thank you for that answer. The one area which you didn't really explain is with the integrated care, as I understand it, correct me if I'm wrong, it will link all local authorities, and the area that we're going to talk about is lots of local authorities. They all have separate budgets. There needs to be a really good conversation about how you integrate budgets. I know, looking at the Cabinet members' budget, there isn't any real room for wriggle, and I'm concerned that doing it on a low resource, with a low financial input, without additional funds to the councils and local authorities and the body of the health service, you cannot succeed without the resources.
I share your view on the resources. On the pool, rather than integrated funding, I'd suggest I think what is included in the bill is modifications to the Better Care Fund that will allow more flexible pooling of budgets between local authorities and the NHS where appropriate. But you're completely right. There is a huge amount of devil in the detail that we need to work our way through to get that right.
I think one of the things for this committee as well is how much of that will be delegated to the Joint Scrutiny Committee to look at, and that's another thing we're very interested in seeing, and how much is place-based and therefore stays with the individual authority scrutiny committees, and that's something we have flagged in the past, and I think we will be looking at quite closely to get a better understanding of that. Councillor Walsh?
Thank you. I think I heard you say that you looked at international models for developing this strategy. If I heard you correctly, and not if I you did, can you just tell me which international models there are more precisely? Because I find that very intriguing. And we can look at the success or otherwise of those systems.
Yes, no, thank you. So let me be clear. The direction of travel is driven nationally and through Parliament. It's not been driven locally and back up. What I was referring to was actually work that I've done in a previous role where we've looked at international models. Some of those are in Singapore. Some of those are in the United States. But where you have an ability to put resources around a whole pathway, you tend to get better flow. So if I take an example of cardiology or cardiac care, at the moment, some of the prevention, smoking cessation, fits in one budget. Some of the primary care, blood pressure, fits in another. Some of the immediate, some of the sort of more, obviously the secondary care fits in hospitals. There's some tertiary care. If you can find a ring fence around that whole funding and allow the people that operate in that to work together across the pathway, you find that they actually move the resource upstream in order to get more preventative work, because the downstream, they see the downstream and feel the downstream impact. And so therefore there is quite a lot of international evidence, very happy to share some of that, that indicates that the integrated care is a sensible way forward to try and operate. And it is one that has been hard to do in the NHS, partly through the traditional silos, but those silos were made worse in a way through the competition that was put into place after the Lansley Act. And what this is doing is rolling back to allow for greater collaboration. What those models from my previous work have shown is they don't reduce cost. So what they tend to do is improve the outcomes and improve the quality of care. They tend not to do the cost reduction, which obviously then plays into your colleagues' commentary around resources.
Councillor Mordew?
I understand that you have 4 main purposes for an integrated care system. How are you actually going to monitor that? Especially the one that says enhancing productivity and value for money.
So I think as you're probably aware, we're always offered opportunities to measure. So there are a set of metrics that are being produced that will, around which the integrated care systems will be measured, and that's across all of those 4 domains. Actually, it's the 4th that is proving the hardest one to actually work its way through. So we will have a set of metrics. The last I saw, there was about 75 of them. I suspect it will grow rather than shrink. And there is also mooting that we will be inspected as well as assessed against those potentially by CQC. So that's the national measure. I'm expecting we will also have a series of programs that we agree to undertake within the system that may have a different set of metrics. So, for example, we may have a greater push on smoking cessation, for example, than is required from any national target, and therefore we would set our own individual targets against those, and obviously the programmes underneath it.
Thank you. Members? Oh, Councillor Addo.
Sorry.
Is there,
Oh, okay.
is there a plan on public engagement? How do you intend to engage the ordinary people in this process? I have a bit of a background because I'm a nurse. I can sort of see what's going on. But a lot of people, even, members of in GP practices, don't know what is going on. And that, to me, is a huge concern. So with all this matrix and somebody's going to check, and the users need to be able to check as well. They need to be able to feedback into the process. So is there a plan to do that? And how do you intend to do that? And is there a time frame for doing that as well at local levels?
Yeah. So so you're completely right. We need to. There is a huge amount of engagement that we need to do alongside this. I mean, to be honest, the first piece we have to do is actually get the proposal of how we're thinking of even trying to do some of these pieces, because it is not actually straightforward to try and do it. There aren't many parallel organisations with a dual board system, for example, that we were asked to be put in place. So actually getting the details of this, or the proposal around this, is important as the first step. We are doing that through engagement with broader stakeholders, so including Rachel, for example, when we talk through on the Buck side. We then need to do a broader set of engagement with the sort of health stakeholders, as you say, like primary care, who currently we're doing a set of engagement exercises around how does the primary care voice, how is that going to get injected into the various elements of the governance. And then once we have that, I think have something that is reasonably robust, we will then be in a position to engage locally with the public. I would say that there is some of this is the organisational architecture as opposed to the changing of any services. So while it's important to sort of keep the public sort of engaged, in particular how their voices are going to be heard as we shape those services, that bit I think is really critical. We're not in any of this at the moment changing any of the services. We are, if you like, rearranging the architecture, particularly the commissioning side of the architecture within the service. But those plans at the moment are not yet fully developed. They're part of the long list of activities and things that we need to plan for and execute against as we head towards April.
Thank you, Sade. Any other members with questions? I'll let Councillor Wassell go first. You've had a go, Robin. Let's hear from Julia first.
That's it. Is that better? The place-based partnerships arrangements, because of the risk of sense of remoteness that Sade has referred to, how local do you think these partnerships will be? Will they be on a county? Is there any chance of getting more to a neighbourhood, or you know, ward-based or division-based partnerships there? How far can you drill down?
So I think
these partnerships.
I mean, obviously, some of this is still in the design, so there is potential. There is potential to you know, we need to work our way through how does the funding get delegated to different levels. I'd say the current thinking would be that the funding will get delegated at a county level. But as you know, we are also working to build out the primary care networks and put increasing resource into those, as well as wrap the community services around those, so that we start to get to, I think, what you describe as more neighbourhood, more locality sort of partnerships in the way the practices are working and the way community services would work. But the core of the funding and the delegation, the partnership that we need in order to be able to allocate the funds as accurately as you can would sit at county level, or that would be the current thinking.
Yeah, PCNs are a subject close to our heart. We've spent a lot of time looking at them, and it's been an ongoing project for 2-3 years now. New members, I would urge you to have a look back through the HASC papers. And we do have some ongoing concerns about the different rate at which PCNs are developing and recruiting to new posts specifically. So we are very keen, and we may even want to look at it at our next HASC meeting as to get an update, because obviously we've had a very difficult year and those PCNs have been at the coalface of matters, and we're very keen to see them improving services, getting services back to normal, but also how they're going to then transition to the next stage. Councillor Stutchbury.
Thank you. I'm very interested to listen to you, but I'd never heard, which I was hoping to hear, about adult and social care. You will know that there is assumptions that they're going to do something on the funding of adult and social care. This change is coming in. Are you anticipating the government bringing the two things in together? Because if there isn't a funding package for adult and social care, I really struggle to understand how it will work, because adult and social care is relying on social care precept and other monies now, and it doesn't look to me, without those changes and those fundings coming in, that these integrated care packages or changes will work. Are you assuming that the government are going to do the two things together? Because they need to be done so.
I'm not sure I should be. Let me start again. I was encouraged to see that there was potential for a social care solution with additional funding being mooted in the papers 2 weeks ago. I was disappointed that got pulled back, but I still am optimistic that they will come forward when we come to the spending review and the budget, that there will be additional funding for social care. I don't believe that the two things will be deliberately sort of locked together. I think they'll run on two separate parallel paths, because one's a bill and one's a budget. But would I be optimistic that by April we have greater clarity and more funding into social care? I think I would be optimistic on that, but that is optimism as opposed to any factual data.
Yeah, I think we're entering the realm of the great unknown, controlled by greater forces than this committee, Robin. But it's an aspiration we'd all like to see solid funding of all services. Councillor Mordew.
Thank you. I think you mentioned the use of consultants in managing the resources of the new ICS. Will they be used in the design of the actual processes of the financial aspects and the systems and flow lines which you use?
So I mentioned the use of consultants to support the design, help us basically flesh out the scaffold. So we have external support around some of the place delegation, and we have external support around the governance. At this point, we have not commissioned anyone to help us through with the funding flows as yet, because I think we have to work our way through. What those place-based models would actually look like. It would not surprise me if that's where we need to go, because there is a skill set. There's a capability and capacity challenge that we have in terms of the work that we need to get done between now and April, and therefore we may well need to do that, but we have not commissioned anyone at this point.
Any other questions from members? I don't think so. I mean, you touched earlier on detailed plans. I mean, certainly one thing we're keen to see is a more detailed plan of how that work is progressing. You were with us, I think, in April, and we were consumed by vaccination programmes.
I believe we were.
A huge extra workload for you and your team. But we are very keen, because obviously, you know, things do naturally slip, but we were hoping to have all of this in place by this September. I think the key date I'm hearing now is next April. So we would really welcome some further clarity on those detailed plans as soon as it's available. I'm sure it exists in the brains of people at the moment, but as soon as you can share some details, we'd like to have a look. I mean, one other point I had reading through the slides you supplied, you say ICS partners have developed better and more convenient services. I think what would also be useful is maybe if you could provide some links so that we can look at some evidence reports that actually highlight how those improvements have been made.
Yep.
I think members would really like to see that kind of detail. Any other questions, follow-up, or anything else for Dr. Kent? I don't think so. Well, thank you very much for coming and joining us, and nice to see you. You're welcome to stay, but you're welcome to escape. I'm sure you have a very busy diary.
Thank you very much.
And we look forward to seeing you again soon.
Thank you.
Okay, we will move on. So item number 7, Buckinghamshire Healthcare NHS Trust Key Priorities. And we've got Neil MacDonald with us today, who is the Chief Executive for our NHS Trust. Welcome, Neil. I shall hand over to you. Neil supplied a report that's in members' packs. I hope you've all had a good chance to read through it. I don't know if there are any extra points that you want to give a summary on, Neil, and then I'm sure members will have some questions for you.
Yeah, thanks, Chair. I'm very conscious I gave you quite a lot of reading to do, so I'll be kind of brief. And again, like James said, I guess the value will be in the questions and answers. And again, obviously, I know some people around the room and some people will be familiar with how health services are configured in this county. But for any new members to the committee that want to spend time actually kind of coming and seeing some of the health services we provide in the county, there's an open offer there for people to contact me, and we'll helpfully kind of add that orientation bit. I guess the key bits for us really at the moment, well, we're dealing with the reality of some pretty challenging operational issues at the moment. I mean, on 3 levels. One, emergency-wise, the NHS is certainly busier than it's been ever before, I think, which is pretty unusual for a late July. But clearly there is a lot of pent-up demand from events of the last 18 months, which is now coming back, and we're having to manage. Clearly we've got a huge nationally and locally backlog of work to get through in terms of some of the waiting lists in particular, and catching up on some of the stuff that we've had to stand down over the last 18 months. And then thirdly, clearly we were in the middle of a 3rd wave, and we have got COVID back in the hospitals, and it does the impact of the virus is with us and will be with us for some time, just in terms of how we operate, how fast our theatres are, how many people can be in a waiting room, the size of our A&E department, the amount of PPE we have to put on. It's had a quite seismic effect on more or less every single operation of our organisation. I think in high-level terms, the priorities for us, so first and last probably, and on my to-do and worry list is our workforce. Clearly before the pandemic, the NHS nationally was not exactly working with a surplus of qualified professionals. There were clearly some significant gaps in there, and the events of the last 18 months have had quite a significant impact across all parts of the health and care sector in terms of what people have experienced, the disruption they've had to put up with, the impact on, like everybody, their personal lives, but professionally there have been some particularly traumatic things that my colleagues have had to deal with. I think particularly December, January, February of the year just gone, and that will take some time to help work through. We will no doubt lose some people who have seen us through the pandemic and who now need to take some time away from the work. And whilst the future pipeline of people entering healthcare professions and higher education is at the highest levels, that will by default take 2 or 3 years to kind of work its way through. So ensuring that I've got a workforce that is able to manage what's to come in front of us is my number one priority. Secondly, we've done some significant work, I guess, in terms of shaping what we think our future clinical strategy will look like in the future, based largely on kind of what we knew about the future of healthcare and some of the pathway changes that Dr. Kent has described, but also learning of what's happened over the last 18 months and how that might change healthcare provision in the future. We will publish that later on this year, and when we do so, will clearly be made available, Chair, to the House Committee and for us to come and present that with some of the clinical teams. That will look at a variety of things in terms of what's the future capacity we need in the county based on the number of houses and the population growth in terms of our emergency services. What is the future of our planned elective operations and the capacity we need? Do we have enough theatres and other such things in the county to cope with those elective backlogs that I mentioned? What's the future outpatient model? Technology has moved on at a faster pace of the last 18 months than it probably has done the previous 5 years. Some of the technology changes are quite staggering. So what does that mean for things like how we monitor people in their own homes, how they interact with our services, their outpatient experience, etc. The integrated pathway stuff that Dr. Kent has talked about, but also what's the future shape of where our community services sit in partnership with our colleagues in the local authority and social care in particular, and then other things like diagnostics and the digitalisation of diagnostics, where major imaging scanners are going to be, and how we give people fast access to diagnostics and the development of the genomic programme, etc., etc. So that's the clinical bits. I guess there are some infrastructure challenges we need to deal with. Those of you who know both the Wickham and Stoke Mandeville sites will know that those sites are rapidly approaching the end of their sell-by date in some of the infrastructure in there, both in terms of the quality of the estate, some of it's now fit for purposeness in the context of having to manage distancing and on the infection control measures, and clearly some significant upgrades needed in terms of the quality and sustainability of that state. So we will be thinking quite hard about kind of how we put together a programme that looks at significant changes to the infrastructure of our estate to bring that into the 21st century, and also to link in with some of those capacity and future population challenges that we know are coming down the hill. Those are the major bits, Chair. I'll kind of pause there and take questions.
Thank you, Neil. Okay, open to the floor. Councillor Stutchbury.
Well, firstly, can I personally thank everyone who's been working through these difficult times and the sincerity and hard work that you've put into it. That's been really appreciated, and I'm really grateful and watched how hard you've worked. I've got some questions which I'm concerned about. Is a small question in the scope of the report. what's your plans with community hospitals? But my more important question is, you mentioned quite rightly retention of staff and how you're going to go forward. We now are not in the same legislative framework as we once were. Now we're outside the European Union. Do you anticipate this being a bar to recruitment, or are you sure that the legislative framework around employing people into the NHS through the government's actions is robust enough not to impede on healthcare, or will we be going to outside European countries to get the recruitment forward, because there's a 3-year gap, a 7-year gap for training, and in the interim you're going to need staff, because many staff, as you rightly said, will have had burnout now through the pandemic, and they're going to need replacing. And I'm unclear what the legal framework for you to be able to recruit is, and whether you'll be able to get enough workers and enough qualified staff in, why hopefully we train our own.
Yeah, well, thank you, Robert. Thank you for the thanks. I know those are sincerely meant and appreciated, so very grateful for those. The plans for the community hospitals. So, you know, as I think Councillor Wassell was describing, you know, those sites as centre points for neighbourhood-based health and social care that communities can coalesce around are, for us, really important. In almost all cases, they're co-located with GP practices, and so having facilities that can anchor in particular parts of the county are really important for us. We clearly have an outstanding bit of work to do regarding the finalisation of the full consultation bit around the changes that were made to Marlow and Tame 3 years ago, I think now. So we will have to close that loop, but it is absolutely core to our future clinical strategy that we have really strong spokes into the community and centres where we can coalesce and build kind of community resources. Regarding the retention bit, so we have net lost colleagues from the European Union who worked in the organisation. We had quite large cohorts of particularly nurses and other professionals who came from Italy, Spain and Portugal mainly. We've lost, as I say, we've lost more than we've gained in that regard. Whether I can pinpoint that to EU exit, I suspect that the majority of it is the travel restrictions of the last 18 months have made it very, very difficult and people quite isolated from their families, and they've taken the decision to go home. In the future, there are no immediate legislative, I don't think, barriers to me recruiting overseas workforce. There are very extensive current campaigns underway that are being led by the national NHS, specifically targeting overseas recruitment in India and the Philippines, and there are some significant numbers of nurses and other professionals from those countries coming into this country over the next year, indeed of which we've received, certainly locally in this county, a cohort of nurses who have come across from India in the last 2 or 3 months. So whether or not that is, I know there are challenges in other parts of particularly the care sector, which I'm less cited on, Robin, in particularly those in domiciliary care and care homes, but for the biggest gap that I have, which is in the qualified professional clinical workforce, there are no immediate barriers I can see at this moment in time.
Thank you, Neil. I mean, you touched on Tame and Marlow, and obviously we had pilot projects for improving services and bringing them closer to the local community. Obviously, that was a pilot. It was extended by a year, and you have touched on the Chartridge ward as well in your report, and there's a lot of concern over the future of Chartridge ward. I mean, it says here that you hope to reopen it towards the end of August. I mean, will that be as an inpatient ward as it was originally, or are you looking to move that, kind of continue with the rehabilitation of people coming out of hospital that need some respite before they progress, kind of returning to home? And also that pilot project for Tame and Marlow, I assume the plan was always to roll that out to further sites, and I wonder if any progress has been made, maybe not in the last year, but I think it's something that the community are very keen to hear next steps on, really.
Yeah, absolutely. I mean, and there were two slightly different circumstances for the two areas. So the Chartered one was a particular challenge we had around staffing levels, and obviously the CQC had their view of it. That will be reopening as an inpatient ward in about 3 weeks' time, so that will come back up. I mean, the short answer, Chair, is that we'll do both in terms of actually, because we do need the right balance of both bedded and then more outreach, kind of ambulatory or walk-in services. I think the data from the original challenge from Tame and Marlow, which cast people's minds back, was the sustainability of those units because they were so small. So it's much easier for us to manage 48 beds in Amersham Hospital than it is 8 beds. I mean, managing 8 beds in a standalone unit is almost impossible to do, which was part of the quality driver of that. We've got some quite interesting data in terms of the volumes of those local populations that have been through the new model and the impact that may have had in terms of reducing further down hospital demand, but obviously it's a complicated picture and there are a number of variables within that space. So we expect actually, when I've referred to the clinical strategy bit that we'll put through our public board in probably September, that clearly there will be an engagement bit that we'll launch alongside that to ask some open-ended questions about what the public want to see in their future health service provision in this county, and we'll start. We touched on that initially last summer, and obviously events kind of with waves of the pandemic overtook us, but that will come through again, particularly looking at some of those different changes that have happened over the last year in how we interact with patients and the population.
Thank you. Councillor Gom.
I thought it wasn't working for a minute, but there we go. Thank you very much for your presentation. And of course, we all know what a great service the NHS do for our lovely country. And it's quite sad that you're just overwhelmed with not enough staff and too many patients coming through. But what I'd like to ask a little bit is your A&E department I know you're highly stretched everywhere, but you're totally overwhelmed in the A&E department. And how do we generate the local GPs to start allowing their patients to come back into them to help your department not to be so overwhelmed? And another controversial question I want to ask is, how do we help manage your A&E department with people coming in with a piece of stick, a little stick in their finger or something like that, or a snivelly nose? It's true, you get overwhelmed with that sort of stuff. So how are you sort of managing, or how can we help educate the community not to waste very valuable time in the A&E department?
Well, I think so 3 points I'll pick out there. So if I start with your last one, so anything that you guys can do to help promote the correct pathway. I mean, I always say that 111 as a first point of access is really helpful, just for informing people which of the many pathways they can go down, because it is complicated actually. There's lots of different acronyms, places you can go, and it is difficult to navigate, and that central access point is really important. My personal view is that actually communications campaigns that tell people to stop going to A&E if they don't need to don't really work, because all they do is they reinforce actually there's a really good open service there and they go to A&E. So we're always going to have, we're never going to kind of eliminate that problem, because people will seek kind of access to services that they think are the best fit. So it's going to be a constant challenge. I think primarily for us in the A&E space, again, we're always going to get people who kind of may have gone to their GPs but couldn't or didn't know to go to their GPs, who will come to us because we've got those types of services. In effect, kind of we build those services in so we can deal with that. So we have got GPs who work in the A&E department. We've got a pharmacist pharmacy that will just be about to be opened kind of next to the A&E department, so we can push people into that. So effectively, if people are going to come, actually, how do we provide the services that can best suit their needs, rather than having them at the back of an A&E queue waiting for the A&E doctor and nurse. And then for us, the real challenge is physical space. That part of the Stoke Mandeville site needs significant redevelopment. It's too small for what it's required to. We've got a full new paediatric A&E department currently being built, which will be open, I think, in about January, February time, which will help in the short term. But fundamentally, certainly over the last 10 years, the amount of capacity we've built, both in terms of physical space and people, has not kept pace with the demand coming through. And then the final bit about the GPs, recruiting GPs has been those same pressures that I've described that my colleagues have been under in the hospital and community services in the last 18 months have absolutely been felt in primary care with GPs. And guess what? They've also been asked to deploy the country's largest ever novel vaccination programme. So there are going to be some pressures in there, and people wanting to reduce their hours or take a break or actually take early retirement, they're going to come through. The volume of recruitment that is, I think that the chair referenced it in terms of the numbers of posts that primary care networks are trying to recruit to, whether it be pharmacists, therapists, all sorts of professionals, are phenomenal. Again, that's kind of got to look at in the wider kind of availability of that workforce, but there is the most workforce investment that's happening, I think, in the NHS at this moment in time is happening in primary care. But there's a reality of that, I guess, the demographic change in the GP population and how quickly you can get GPs into substantive posts, which, again, has been a systematic problem for quite some time.
Thanks, Neil. I mean, just in that vein, I don't know if you've got any anecdotal evidence about how residents are managing to access GP appointments. As local councillors, I think we all kind of hear rumblings in our inboxes, but in terms of actually understanding the extent of that problem, and it does go back to what Phil was saying about there are some patients who habitually want face-to-face appointments, and it might not necessarily be the best way to deal, or best use of GP time, or best use of patient time. So I don't know if you're experiencing real problems with patients choosing to come to A&E or access hospital services direct because they're struggling to access their GP.
So, anecdotally, yes, but it kind of always happens as well. And that sometimes gets magnified in the hospital where I work, because an A&E consultant will kind of experience a patient who's kind of turned up in A&E and said, I've tried to get through to my GP on the phone for 2 days, couldn't get through, and then I've turned up. And that kind of gets amplified a bit in terms of that messaging part. What I do know is that I think primary care has seen and processed more appointments kind of in the last 6 months than it ever has done before. So there is clearly access is being provided like it never has before, but clearly demand is probably greater than it ever has been before. And again, we're about to go into what is likely to be an autumn campaign around potentially a booster campaign for the virus plus flu, which is going to put those pressures on as well, really. So my personal view, not being a primary care expert and someone who doesn't work in primary care, is that one of the greatest challenges is the variability. And I think some practices do it really well and are really slick and have got and some practices will be less so. That's just kind of life when you're working with 55 different independent kind of businesses almost providing kind of care services. And so kind of helping kind of those who need our help a bit more, I think, is quite important for us to support those packages going forward.
Lovely, and something maybe we can pick up when we look at PCNs later in the year, when we revisit that. Councillor Poll.
Thank you, Chairman. I'm afraid I was reading my papers when the declaration of interest was called out, but just for clarity, my wife is a current employee of BHT, my son as well, but the questions that I have do not relate to the work that they do there. Key priorities, Neil MacDonald. You have 6 headings there and then go into subheadings. And I just wanted to pick up, so it was page 67 was the key priorities for the next 12 to 18 months, which then page 70 are expanded upon, particularly to recruitment. Now, in Buckinghamshire, we particularly suffer from, we hear it constantly in this council and the previous authorities, that we educate people and then they move out, where our proximity to London means that they're educated here and take a career elsewhere until they move back, perhaps to start a family. But we're losing that cohort, 25 to 35. The education process within the NHS, I understand that the university placements for nursing this year are full. Perhaps you can, let me know if that is the case. So, can other pathways be used to fill any vacancies that we have within BHT? I see that you're already working with the Local Enterprise Partnership and Buckinghamshire Council to advertise for nurse candidates and healthcare candidates. Are we, as an authority, Buckinghamshire Council, doing all we can, bearing in mind that since our formation 18 months ago, not quite, 15 months ago, we've had the unusual COVID situation like everybody else, so perhaps jobs fairs and things like that have been difficult. So that's on the education. And just finally, you mentioned about expanding or remodelling Stoke Mandeville. Some years ago, some of the land was used for housing and a small supermarket. Bearing in mind what is required of the old buildings that are nearing the end of their life, I take it that the decision's been made. All that land is occupied. But will Stoke Mandeville have the space to do what is necessary to transition to newer, more appropriate buildings? Thank you.
On the nursing recruitment, I guess, so direct question in terms of are the universities full? I don't know the specific answer to that, but I do know that they've had more applicants than they've ever had before, and they're working quite hard actually to build in more teaching capacity to be able to cope with those, which is good. That hasn't happened for several years, so that's a positive route for us. We took a decision about 3 or 4 years ago to significantly diversify our sort of supply chain for nurses. So we solely worked 4 years ago with the University of Bedfordshire. They were our contractor for supplying nurses. It wasn't, I think, best practice just to have one supplier, so we worked quite hard with Buckinghamshire University, for example, to help build their nursing education programme. So we now take students from Oxford Brookes, BNU, Bedfordshire, so we've got a more diverse supply. So that kind of gives us a better robustness of supply coming through, and then obviously we manage things like the number of placements we can provide and on-site and in clinical practice supervision. I think there are multiple routes now into nursing than there used to be, so there's still clearly a higher education route, but we also now we commission contracts to do things like nursing associates and nursing apprenticeships, which again are in some way some of them are kind of a bit of back to the future in terms of the old enrolled nurse model that can kind of come through, which was a bit more of a vocational practical training program rather than the specific kind of classroom-based program as well. So we've got also more diversity of kind of different routes that people can come into nursing. So as I said at the start, it does look for us, I think, a much healthier order book, if I can use that term, in kind of 2 or 3 years' time. But we've just got a couple of years, I think, where it's going to be a bit tight. But clearly, as I was mentioning in my other response, we will probably take more numbers of international nurses over the next 12 months than we've probably done for quite a long time. The space at Stoke Mandeville, I mean, those. I was first at Stoke Mandeville in 2005, and what was my office then is now someone's living room. And kind of when I came back in 2013, obviously there's quite a large chunk of that site is now housing, and as you say, the Asda bit. I don't think the total space on that site is probably not the problem. The problem will become in terms of how you redevelop and build a hospital in situ. That becomes very expensive, as you can imagine, because you're trying to build something with something already there, and you can't just take a break from A&E for 2 years while you build a hospital. So I suspect that will become, and we'll have to have a think about kind of where all the housing is going to be in the future. There are clearly some significant infrastructure transport changes happening in the region in terms of the railways and potentially new roads being built. So we'll need to take all those things into consideration, really. But I've got no immediate kind of plan or firm thing that kind of would point to what the end result will be. I think, there now exists the Buckinghamshire Health and Care Academy, which is now a formal partnership between the Mental Health Trust, us, the council. Again, I think in terms of activity for the last 18 months, for obvious reasons, potentially kind of, it hasn't progressed at the rate because we've been dealing with something else. But we feel is progressing kind of really well, and is a good branded opportunity for us to collectively work with higher education, colleges, etc., about getting people not only into professions, but obviously all the other support and care and people we need to do a variety of roles. So yes is the short answer.
Thank you, Neil. Julia.
Thank you. Well, you did open the door to discuss infrastructure, and you mentioned Wickham. Last time there was a development, you had to rely on PFI, and it has left quite a big debt with that Taylor Wimpey development. And unfortunately, the government hasn't wiped out any of the PFI debts, although they've wiped out some other ones. Is there any possibility that the one public estate arrangement could be helpful? Because you may know that the local authority has a big estate at Saunderton, which has been a homelessness hostel, and is now moving into the town centre. So there is some movement around the public estate. I'm concerned about the birthing centre. It doesn't seem that definite that it will reopen, but you may have some news about that. So how do you see any redevelopment of Wickham Hospital, which urgently needs it? And what about the birth centre? What's happening there? Thank you.
Yeah, thanks, Julia. I mean, the one public estate process is helpful. It's allowed us to identify some kind of perhaps smaller scale projects that we perhaps wouldn't have done previously. But the fundamental challenge for the NHS, particularly when it comes to hospital development, refurbishment, rebuilding, whatever you want to do, is how the capital regime works in the NHS, the allocations that the NHS gets from the Treasury, which of course are, we would argue are never enough, and then how that gets distributed across the country. And the reality is what I've got, my capital allocation that I get on an annual basis for an organisation that turns over about 450 million is about 15-16 million pounds, which if I was in Rachel Shimon's shoes, I would call probably a maintenance budget. So it's not a it's never going to be something that's going to allow us to resolve some of those kind of long-standing problems. So the challenge becomes in terms of how we generate capital, which back in the late 90s was the policy direction that led to PFI, and a way of dealing with investing large amounts of money in the NHS estate whilst keeping it also off balance sheet. There is the only policy currently in place in terms of allocation of additional capital for hospital development at the moment is something called the Hospital Improvement Programme, which is a national programme. It's the Prime Minister's 40 new hospitals, etc., etc. That, so far to us, is the only route to be able to access capital to do those things. And as you can imagine, that is quite a competitive process because everybody, feels that there is a estate upgrades to be made. So we make the arguments in terms of investment. There's some reality in terms of some of the quality of the infrastructure, and we have those conversations with our regulator, Julia, as you'd expect. Interestingly, the PFI, the first contract break on the South PFI, which is Wickham, part of Wickham Hospital and Amersham Hospital, comes up in 8.5 years, which feels like quite a long time ago, but given it was signed in 1997, actually is something that we're starting to plan for now. So, sorry, the birth centre. Yeah, I mean, we've had some real challenges just in terms of particularly in waves over the last year in terms of number of midwives, effectively. And particularly when the first and second waves were coming through the organisation, if you lose 10% of your workforce because they themselves have the virus or have to isolate, that has been clearly some problematic, plus also in my previous answer in terms of loss of some European colleagues who've gone home, there's quite a large cohort of Italian and Spanish midwives that went as well. There's a big chunk of investment gone into the midwifery workforce. We do value Wickham as an anchor point in terms of being able to reach out into its community, because actually we know some of the maternity outcomes in Wickham are not as high as other parts of the county, through reasons of clearly sort of deprivation and overall health in there. So having a centre in the middle of Wickham is really important for us. So it's absolutely our intention that will be reopened. I think when we said in November, December, I think is the current workforce plan to get that done. So we know the numbers of births there are relatively small, but actually it's more important as a community base for women in that part of the county to come and access and speak to midwives. And so. It's always been December, but we may be an outdated bit, councillor. So anyway, but that's the current workforce trajectory.
Councillor Walsh.
Thank you, Chair. You mentioned in your report the use of the private sector, and I'm interested to know, and you specifically mentioned the Chiltern, I'm interested to know to what extent you use the private sector, and especially over the next few months. And to me, it sounds expensive. So can you just give us an idea of the cost and how that's going to be met by the NHS? Thank you.
So the NHS has always used the private sector. I mean, the private sector in Buckinghamshire is not particularly large compared to some other areas, which is perhaps surprising. But the PCT and then the CCG have always had a contract with the private sector, because part of the choice agenda that the government brought in several years ago was that patients would have access to a number of different routes. So the BMI, who run the Chiltern and the Shelbourne hospitals in Wickham and Great Missenden, have always had an NHS contract where they do NHS work. Clearly, actually, particularly when the first wave happened, all private work stopped, and we took over that facility in its entirety, and that was funded nationally through a national contract arrangement that was made. Those contracts now have kind of come down for local ownership, and so they can be used with some nuance about what's needed for the local population. Clearly, left to myself, I do not have the capacity to deal with the number of people that are now waiting for operations, etc. In fact, even if I add on BMI as well, we probably still don't have enough, and we're going to have to do something additional to that as well. In terms of value for money, I guess the price that a contract entails with a independent sector hospital is exactly the same price that I receive. So it is a standardised national price menu, I guess. So what we pay for a hip operation in the Chiltern is exactly the same as what I get paid for a hip operation.
Just to clarify, Neil, I mean, the report says there are nearly 700 longer waiting patients in pain who'll be invited for treatment at the Chiltern. I mean, is that just part of the scale of the problem? Do you know roughly what the total number of patients waiting at the moment for treatment might be?
My entire waiting list. I think people waiting for operations, I'll caveat this in terms of it's a moving number. We're trying to reduce it quite quickly, and it won't be what I say won't be accurate to the patient. I think roughly in terms of people waiting for admitted procedures, it will be around 7,000. I think. So the total waiting list in everything, people waiting for outpatients diagnostics, will be about 30,000.
Okay. And you'll be glad to know my mum is having her hip operation at High Wycombe next Wednesday and is very grateful for the Bucks NHS service. So there are some positives coming out, and people who have been waiting for a while are now kind of moving through the chain, as it were. Sade, I think you've got a question.
Thank you very much, Neil. Good to see you. I just want to say thank you to the staff. My colleagues are still there for the work that they've been doing since last year, and the experiences. And I also want to say, and I don't know if you hear this a lot, Neil, but particularly with my last colleagues from the district nursing team, to say thank you. And they all talk about your relationship, coming to visit the centre, Desborough, which is very good. So I just want that to be, if they don't tell you, but I do hear it when we all talk on the platform. And following on from what the chair has referenced on surgery, taking place now, how is the trust working, looking at the backlog and the winter issues? Because I remember being in A&E and we facing these issues of coming to winter period. Is there a plan in place? And I hope there is, and I'm sure there is. But how are you planning to cope with that pressure that will be coming on, considering the delayed surgeries and other emergencies that are going to be in place? And following on from that as well is the handover that we used to experience, from ambulance colleagues coming through the service. Is that still going on? Also, how are you working with the South Central Ambulance Service on making sure that delay in handing over patients is being taken care of in light of our current situation with the COVID? Thank you.
Well, thank you for your comments. As chief executive, you're not supposed to have favourites, are you? But I always enjoy kind of my time with the community kind of teams because they're a great bunch. In terms of that forward plan, so there is one very complicated issue that Dr. Kent referenced, in the fact that I don't have a budget yet for September, which makes kind of investment decisions kind of quite tricky. I guess one of the really good setups in this county is the split that we have between Wickham and Stoke. So that allows us to protect beds and theatres for people who need operations, which in a normal kind of winter serves us really well, because we can get through that work and it's protected from some of the pressures that come through the A&E department. The critical issue really in the pandemic was never really the space, it was more the people, because of course if you're going to double or triple the size of your critical care unit, you need the anaesthetists, you need the theatre nurses to come and help kind of support and run those facilities, because they're particularly trained in looking after really unwell people. My sincere hope really in terms of if the pandemic continues at the kind of current forecast rate going into the winter period, that actually we won't need then to pull those staff into those critical areas, and we can keep the elective centre to running. There'll be more to do as well. We've touched about how we're properly making the most out of the independent sector also, and in fact actually we might be in a position where we're making decisions about actually some of the capacity we need to build onto the Wickham site. There is also, we should be making best use of the capacity that's also available to us across a wider footprint as well. So working with colleagues in Oxford and Reading about actually, is there spare capacity that we can use going through. The ambulance service, when I described the pressure in the health service, is absolutely felt there. There is always a perennial challenge in terms of making sure we get ambulances offloaded quickly and get them back on the road. And I think particularly in the second wave, that was a really key challenge in terms of how overwhelmed some of those services was when we saw the virus move around from Kent across the southeast and across London. Actually, we learnt as part of that process, we designed and learnt new models for how we could create space to allow ambulances to offload into safe areas and be put on the road back a bit quicker than we had done in the normal winter kind of A&E experience. So again, we'll be looking to work with the ambulance service again, how we usually do that, and I think they've also just been given a slug of money to help them support in terms of resilience, because clearly I think their 999 and their 111 services are under significant pressure, which is just the weight of that kind of pent-up demand pushing its way through.
Councillor Heap. Okay, we will move on then. Councillor Gom, I think you've got a follow-up question.
It's very nice of you, Chairman. Thank you very much. Again, overwhelmed, under capacity. So the question I'd like to ask is a bit of a weird turnaround, and I'd like to follow on from Councillor Wassell on this, is to do with midwives. Like, you said you've lost loads and loads of midwives. You're trying to recruit as quick and hard as you can. Has the demand increased? The reason I turn my question is because certainly over the COVID period has been a dramatic time for everybody. But we've had mental health increase, we've had domestic violence increase, and I wondered, everyone's at home, as babies increased, which is going to, well, it's a true question, isn't it?
I wondered where you were going with that, Councillor.
Well, no, I'm coming out. So has that put any more demand on your service?
The birth rate did increase, and we had a very busy period about 2 or 3 months ago. So you can do the maths and work back to kind of when that might have kind of come from, if you wish. I mean, I think there is the birth rate actually in the county for the last 5 years has been fairly flat, if not declining, and it hasn't increased in the way that people thought it would be. So there was a time 5 or 6 years ago where we were worried about our the capacity, the future plan for birth capacity at Stoke Mandeville in particular, and those haven't materialised. Whether or not that will change now. In terms of, we haven't lost kind of tons of midwives, but when you have a midwifery workforce of about 120 and 10 suddenly go back home to Europe, there's quite a big chunk of the workforce then to cover, which has led to some of the challenges I was explaining earlier. Actually, again, a bit like nursing, midwifery has had a big growth in terms of applicants for people coming in. One of the areas that gives us confidence for the timeline I was explaining to Julia was that we, as a trust, we kept all our students. Every single student we had last year has stayed with the organisation, which is, sometimes they go off to, if they live kind of in different places, but we've kept them all. So we're pretty confident going forward. And there's also a big slug of investment coming down from the government that we've received around bolstering those midwifery numbers, because models are changing. There's a programme called Continuity of Care, which tries to give the woman the same midwife from the antenatal through to birth through the postnatal bit, which just by default requires more midwives. And I think you had the Ockenden report come through here last time around, and Heidi was here to explain those things in some detail. So.
Yes, I was going to refer members to the last HASC meeting. We did have Heidi who came to talk to us about the Ockenden report and changes that will be happening to the service locally. It's good to hear actually retention of students, because obviously a key put my teeth in KPI for organisations is retention of staff and how they move and progress through the organisation. So it's good news to hear that your students are staying and working with the trust and continuing on their employment pathway. Councillor Stutchbury, I haven't forgotten you.
Yeah, well, firstly, it's been intriguing listening to the questions. My real concern is that listening to everything you said and managing the weight of responsibility that is placed on your shoulders. We have been through a situation where many cases and situations, healthcare outcomes, medical diagnosis and mental health, whatever you like, have been delayed. People will have been self-isolating, hiding away from their obvious conditions, and are now going to present themselves to the NHS either through a GP if they can get to a GP appointment, because they want a face-to-face appointment, as was mentioned earlier, and they're not getting that necessarily, and they fear talking on the phone. And diagnosis, I've seen and talked to people, you can get 3 diagnoses before you get a treatment with 3 different GPs. So I think that you're going to have a tsunami of cases coming to you. You've got a finite budget. You've gone through one of the biggest strain on your resources possible in the past period, with some extra resource, to be fair. I am really concerned that you can cope with that and deal with that coming forward. The outcomes of patients will be restricted and probably not so good as they would have been. Plus, you've got, as we've just heard in the earlier session, the integrating care package change going forward, all at the same time, all trying to manage that, plus buildings and projects, which is always, people want to stand by buildings, but outcomes aren't done in buildings, they're done by NHS staff. So I just want to understand how you're going to manage that, because I fear it's going to be difficult for you, and there will be, unfortunately, people who don't get the care they would have got normally, and that's not the fault of the NHS. People have got to fall by the wayside, and that's the honest truth. It's not meant to say that, because if you've not seen and you haven't been and you get a late diagnosis, your outcomes aren't so good.
Yeah, so it's a quite a big question.
It always is.
I think,
it always is.
you know, I think the yeah, I mean, you know, who knows in terms of what the kind of the secondary, tertiary, impacts of, subsequent to the virus in terms of, as you say, pent-up demand, people who've not been seeking care, people who've been isolating and missing those social connections. We know that has an impact on people's health. Vulnerable people who've been at home and not been active and therefore, have progressed on the frailty pathway a bit more. There's loads of stuff that people who are cleverer than I am kind of working through and trying to model what that means. Clearly, we do it. We've risen to some significant challenges over the last 18 months. We will continue to do so again. I think we know actually much more about our populations and people who are in our care than we ever used to do in terms of the detail and really understanding who are the most vulnerable, who are the most in need of care, rather than who shouts loudest or who's next on the waiting list. We're starting to get into those details in a much more sophisticated way than we were ever able to do. I would be naive to say that actually at times, we need to make choices about prioritising the care for those that we can have most impact on and are most vulnerable. And, there are going to be some challenging months ahead as we work through a winter and that impact. And we will clearly manage as best we can, by trying to give people hope, to prioritise sensibly, and to use all our available resources to the best that we can. So,
lastly, will you be recording the increase, because you need to record the increase coming back to you, because there will be cases which have not been treated. We know of cases which are waiting. It is no one's fault but the pandemic. That's going to come forward. There's going to be a wake coming towards you, like a tsunami of cases which you haven't got an additional resource to do. You haven't given me any sight that there's a body of work being done to assess this. We need to assess this at the early stages, because there's a spending review coming up. Miss the spending review, miss the funding, you're into the next 12 months, and then you're eating into other resources which won't fund the Wickham Hospital, won't fund the GP things, won't fund the such and such, because you'll be using your resources to mitigate for things that you can't do. So you need to get an early sight of it, because it will break the bank.
Yeah, I think you're painting quite a bleak picture there, Robin. I mean, I think we also, yes, it's important that we scrutinise these details and make sure there's a robust plan in place. And I think Neil has kind of laid out several, areas where we're planning well. I certainly looked through the report and saw a lot of positives, things that we're proud about in Bucks NHS. And there are, considering what our health teams have been dealing with over the last year, there are numerous other things that have been going on. We've seen digital transformation within the hospital network, for instance. We shouldn't underestimate those new technologies coming through. The reference to the, I think it was the cataract operations, we were the first trust to actually get those services back up and running. So you're absolutely right. We do need to make sure there is a robust plan in place, but you're painting a fairly bleak picture, and I think it's something that we will continue to monitor.
I'm sorry if I was being bleak, Chairman. I was being realistic. I'm agriculture. I see things as they are, not as they might be.
It's all about perspective, Robin. Julia, did you want to come in on that?
I was wondering whether next year Robin could take part in the audit letter. In the annual accounts? Yes, the annual account, because, he would see things more broadly, more strategically, including the outstanding rating for compassion and so on.
That's a very good suggestion. I second that. Assume we're all in favour and that motion is carried. Congratulations, Robin. You will be part of the working group, hopefully, and I'm sure
you'll enjoy every moment of it. Thank you.
Thank you, Chair. Neil, I note in the report that it mentions that a key objective for the Trust is to take a leading role in the community. I wondered if there is a delivery plan for this objective at all, on how you are going to achieve that, and do you have any additional resource to carry that out?
Yeah, well, I think Dr. Kent's previous answer about kind of what good looks like in integrated care in terms of how resources we can now enable things to be moved around and used in a slightly different way. So as the secondary care provider in the county, I consume the vast chunk of the resources, largely treating people who are poorly, who walk through my front door. And actually, if some of that money was better spent on stopping people coming poorly, I would need to spend less, and it would probably lead to a better outcome, and it would be better value, if not reduction in overall costs for the taxpayer. One of the things that particularly the last 18 months taught us is that, as an organisation, we're a big employer in the county, we're a big owner of real estate, we clearly spend a lot of time trying to make poorly people better. Actually, we've not over the years spent enough time thinking about what role we play in the community, whether it's equal access to employment or taking education and training out into the community. We've got an opportunity with the community boards now to do that kind of much better. When we run education programs about diabetes or obesity or cardiovascular disease or whatever it might be, actually we should be doing those in situ in the community, not expecting people to come to us and to do it. There's a huge agenda, I think, around children that we could be doing more in terms of working with colleagues in the local authority and voluntary sector. So there's a huge amount of thinking happening in this space. We've now got actually more data than we've ever had before about our population and kind of what their future healthcare needs might be. Again, as we go through the integrated care system journey and work out what that means for us, actually then how we take our services out into the community will be a big driver for us, really. So.
Thank you very much.
Okay, Councillor Grant, we'll take the last question from you.
I'll allow this to be the last question, Chairman. I just wanted to say this is a very serious select committee, but I would like to say, if everyone hasn't noticed, the sun is shining on Neil at the moment. So there we go. Thank you.
I did notice kind of halfway through that kind of somebody was...
Or is it a spotlight? Well placed by Ida, who knows? Thank you, Neil. I mean, interestingly enough, you've talked about an operational plan being developed with the Bob ICS partners, and Dr. Kent's talked about kind of report coming later this year. So hopefully we'll see a lot more of this detail integrated into those, and they'll be side by side or integrated into one report. And we look forward to seeing all that. And again, I'd like to echo the thanks to all of our healthcare providers and to your teams who've done such an outstanding job over the last 14 months or so. And we appreciate there will still be pressure for some time to come, but it's heartening to hear that services are being stood up, and good luck. And we will see you at a HAS meeting soon. I know you have to run off to another meeting. Thank you for joining us. Good to see you both.
Thank you very much.
Take care. Microphone, look at that, Chair, for getting the microphone. Yeah, Zoe is isolating at the moment, so can't be with us today. But we do have 3 members of the committee who actually sit on Health Watch Bucks. And I believe Councillor Mordew has had a chat with Zoe and is going to give us a quick update on the Health Watch item.
I seem to have drawn the short straw following the telephone conversation I had yesterday afternoon, but I would just like to say how much I thank my co-directors here, Carol Heat and Shadia Deo. One of the things we have recently done is launch our annual report. And within that report, there comes the fact that there was over 2,000 hours committed by volunteers into the Health Watch scheme. So basically, without the volunteers, Health Watch would not function. And Joe will probably do the annual report at a later date. On the website, we've had 124,000 hits, and we actually passed on 162 people who were struggling to find out where they could get care from, and we pointed them in the right direction. We've been involved in dignity in care. And the good thing, HAZAC was mentioned in the annual report and accounts, which I think has been circulated. If not, certainly it will be. And we do this on a very small income. So that is basically thanks to Zoe for managing our funds in the best possible way and providing value for money. So that's basically my introduction to report and accounts. I don't have a PowerPoint presentation, you'd be glad to know. But I have notes which will probably last about an hour, but I've pasted it down to about 5 minutes. I just want to highlight a few points that the Healthwatch Bucks has been doing. And one of the first ones projects we have undertaken is Ask NHS, which is something using AI and a virtual assistant who's called Olivia. I've never met Olivia, but quite a few people have. And we conducted a survey in February and March to see what their responses were. And it's quite revealing. Most people were pleased with it. But with any survey, it's only as good as what you do with the information you gather. And all our surveys, we take pains to actually pass the results on to our partners such as CCG, Health Bucks Trust, and whoever is actually working with us. Another one we did was on the vaccination programme to ask people what they thought about how they were signposted to get to the premises in the first place, how they were actually got their vaccine, and so on. And we had 4,543 people respond to that, of which 181 people said they weren't going to have a vaccine. And I personally find it interesting because, it's a free country and people have free choice, but all these facts are passed back. And in this case, it was passed back to the Buckinghamshire Clinical Commissioning Group and the Bucks Vaccine Cell. And there will be a full report on the vaccine findings and the period between April and June. So that'll be happening probably in the next month. Earlier, we talked about the patients accessing the GPs. And in Buckinghamshire, there were 2.3 million applications for practice appointments, of which 50% were on Zoom, I better not say Zoom because I'm advertising. About half of these were remote. So it gives you a good idea how it's going. In fact, after the annual report, we did a survey to ask those people attending our report launch, how many people would like the next report and accounts done on Zoom? And it was something like 85% that would prefer it on Zoom. However, that has to be taken in a context of they were actually on Zoom already. So we will do another survey before the next AGM to see how the ground lies. One of the main points about accessing your GP by social media, whatever you want to call it, was from people who didn't have access to being able to do it. And although we say we live in a digital world, when you get out into the villages, your Wi-Fi and your broadband can be very, very low, and it's very difficult to actually get on websites to access GPs. And we'll wait for the full report on that. And again, if you've got dementia and you're living on your own, you sometimes get confused on how to make an appointment using Zoom. The other point was that on community engagements, with several health watchers who work together, and such as Reading, Wokingham, and West Berkshire, and Oxfordshire. And these enabled us to pool our findings in surveys such as on dental care and patients being able to access their dentist. Care homes, and we've come up with recommendations. And all these communications being shared with the Buckinghamshire, Oxfordshire, and West Berkshire integrated care system, which you all know and love as BOBS. I don't really have a lot to add. So has anybody got any questions?
Councillor Stutchbury.
Yeah, thank you, Councillor Morgie, for first stepping in and filling in and giving a report. I've always had an interest in learning disabilities because I had speech therapy when I was younger for quite a number of years, and people with ADH and mental disabilities and learning disabilities. What do you feel is the future of that, and how do you feel that they're going to get what they need out of the system? Because if you've got a speech therapy problem that isn't addressed, you'll never access any of this, and then they'll never find out that you've got dyslexia, and you won't get on at all. So I really feel that there is an undercurrent there of people who will then, if they're not progressed, prevent issues later on.
Thank you. I have a son who's got dyslexia and I have a grandson who's got dyslexia. So I'm familiar with the problems that they have. But I think in any system, whether it's a council or a care system or a health system, you should be socially inclusive of everyone, not exclusive. And the problem is that people with dyslexia, as you know, computers have actually helped once they get to use them, because they can solve a lot of problems. I think the main thing as far as the future goes is we recognise there are people and groups of people that have problems, and we take into account their needs as much as anyone else's.
The other thing, Councillor Morgie, was the speech therapy, which is really key. If you cannot speak and communicate, you can't do anything. How do you feel that's going to go forward? Because it's always been a Cinderella service, let's say.
Well, in Buckinghamshire, we do have a very good, although you may not agree, adult social care system. And they would go and help people who do actually need face-to-face communication. And even the CAB have an outreach program which helps people who cannot access or understand forms, and form filling is one of the worst things. I can't foretell the future, and all I can do is take on board your comments and bring them to the attention of Health Watch and any other body.
I was about to say the same. Obviously, thanks to Councillor Morgie for coming in, giving us an update in Zoe's absence. But yes, I think your question kind of touches a little bit on a kind of analysis of quite a specific area, which I'm not sure, I may be wrong, isn't kind of Councillor Morgie's area of expertise. Councillor Grom, did you have a question related to the report in the papers?
Yeah, well, it's just to follow on from Councillor Morgie, which I find really stimulating to read this. So I'm a primary carer as well, and I'm a member of the Carers Bucks, because you have to be. But I'm a newbie to the council again, so in a sense. And as a member, I'd certainly like to promote this. It hasn't been put on my desk to promote, but now I've read what I've just read. I've been on your website. It's amazing. So, yeah, definitely want to get that message out there. And I think that should be expanded on slightly, but fantastic.
Yeah, I think you're right. I mean, I wasn't aware of Health Watch Bucks until I joined the HASC a year ago, and they do some incredible work, and you've outlined the fantastic amount of work they do on a volunteer basis. And we are very lucky in Bucks with the number of community groups and volunteer groups that we have, and Health Watch is a very important one. I mean, I find this particularly interesting because I think certainly Liz and I have made great strides to improve communication with Zoe over the last year, and in particular about future meetings and potential work programmes. programmes and trying to get a better understanding of the areas that Health Watch are going to focus on and feedback our areas of concern, because Health Watch are a fantastic tool for actually talking to our residents, and we can sit here and pontificate about what good outcomes for residents are, but really we need to hear from them, and that's why Health Watch is invaluable to us. A couple of things coming out of this. I mean, the first one, Ask NHS, it highlights the need for increased communication with patients, and absolutely, and I touched earlier on the piece of work that David Williams has been doing about digital engagement, and I think that's something we need to watch really closely. I mean, I noted you said almost 50% of general practice appointments in Bucks have been held remotely. I think the next stage is, well, what was the drilling down into the quality of those engagements? Because if people got good outcomes from them, then we're showing that technology is playing a huge part in opening up access to services and to GPs, and kind of changing the mindset of how we access some of those services. And I like the vaccination programme information as well, and I think it's important because Neil MacDonald was saying to us earlier, he touched on the potential booster programme. So we need to make sure that everybody who has had a vaccination is fully engaged with that booster programme, so that we ensure the continued safety of our residents and you know, high numbers of vaccination. But it's also important to understand why people haven't accessed the vaccination programme and how we can encourage them to do so. So I think we will continue to work very closely with Zoe and make sure that, you know, we try to align wherever possible on subjects, because I think there's some really valuable feedback from our residents that can then inform some of the discussions we have either at this meeting or as we undertake some other bits of work throughout the year. So thank you, Howard, for stepping in at the last minute. Right, we will move on to item number 9, which is adult social care, and we've got Councillor Angela McPherson, who is a Cabinet Member for Health, and we've also got Jill Quinton, who's our Corporate Director for Adults, Health and Housing. So I shall hand over to Angela. Now has the spotlight on her, the ray of sunshine.
Very well orchestrated, Chairman. Very well
You have a certain glow about you
I have got spots in front of my eyes now as well.
So we'll hand over to you, Angela.
Thank you very much, and very good to be at this meeting and to hear everything that's been said so far today. It's been very, very interesting indeed, and thanks for inviting me. So you've asked me just to briefly, and I'll just take a few minutes to outline priorities and challenges for the portfolio going forward, and you'll all have seen the paper in your pack, which is relatively detailed, but I just wanted to pick out a few of the main priorities. And it was really interesting hearing James Kent earlier trying to unravel and describe the new ICS and how that might work, and wade through the pages and pages of guidance on that. But I would concur with him that one of my priorities as the Health and Wellbeing Board Chairman newly appointed is to make sure that the voice of Buckinghamshire is heard loud and clear as we move towards that new setup. And Julia, I think you raised actually not just Buckinghamshire, but the voice of neighbourhoods within, as we call it, place. And I think there will be scope for that, and we need to make sure that there is scope for that going forward. We're a large county, we're a very varied county, and we need to ensure that we have that sort of micro aspect there as we move into the ICS. So that's one of my priorities, and the Health and Wellbeing Board will be having that on their agenda for the next few meetings. In terms of the portfolio, the Health and Wellbeing portfolio, it's not just social care, adult social care, it's also public health. So I'm over both of those areas. And obviously, as you're aware, members of the committee, my overarching priority for adult social care is supporting and safeguarding our most vulnerable residents, and they include frail elderly residents, residents with disabilities, and residents with learning disabilities. And from a public health perspective, we obviously have quite a large number, around 9 mandatory services that we must deliver, that's mandated from the government. But also it's imperative we continue to work with partners to help improve health outcomes and tackle inequalities, which unfortunately have widened since the start of the pandemic. That's not just exclusive to Buckinghamshire, it's across the country. Alongside this, our other third priority is that our response to COVID continues. We're still in a pandemic. We have robust recovery plans, and they will remain central to our work. And while COVID did dominate last year, the last 15 months, my personal commitment to the Better Lives strategy, which I think you're all aware of, remains. That is due for a refresh, but basically its focuses on enabling people to live independently and in the best setting for their needs. And I strongly believe, as the leader of this portfolio, in a preventative approach. I think it's absolutely imperative that we hold on and protect the areas of work that deal in prevention and provide the possibility for people to live in a community or home setting and prevent escalation into more acute services. Additionally, a priority for me, and I'm sure Jill will add to this, is that we focus rigorously on quality improvement of our services. And as custodian of the largest revenue budget in the council, we instill a rigid and frequent review of our budget at budget boards. So you've asked me to just talk about priorities, and you'll see that in the paper, but I'd like to just pick out 4 key things that personally for me are really, really important. And the first one of those is mental health, which in my view must have parity of esteem with physical health. We are absolutely hearing about the impact of the pandemic on people's mental health, and there is a significant amount of work picking up in the Directorate to look across the spectrum of mental health provision, from acute interventions around eating disorders, let's say, suicide prevention work, which is sadly has been on the increase, and how we look at community provision and how we provide that to the best effect for our residents. My second area that I'm absolutely passionate about is that we look very hard at how we support and enhance our offer to our carers. Carers have been mentioned, I think, by Councillor Gom, and many of them in this county, a large proportion are unpaid, and they are key to helping people, particularly people with dementia, to live in their own homes and provide that care that they need. So that's another area that work is commencing, but obviously our focus has been on the pandemic, so that's going to be kicking off, and I'm happy to come back to committee to update you on that. 2 other areas of priority, Chair, if you don't mind, is partnership working, continuing to build those strong relationships with the NHS partners, of course, is absolutely key. But more than that, I absolutely loathe silo working, and I believe we need to work across all the directorates in the county, in the council. We've got a very cross-cutting agenda, particularly with public health, and we need to work with our community boards to deliver some of those public health initiatives. We need to work with our housing teams and look at what sort of housing provision we may need going forward into the future. Naturally, we will work closely with the Children's Directorate so that the pathways of care are seamless and those transitions are as good for people moving into adults as they possibly can be. And things like working with planning, which sounds a bit strange, but we're developing a new local plan, hopefully to be enforced by 2025. There's a lot of public health outcomes that can be delivered from working with the planning team. So Jill's very aware of my desire to not be inward looking, but to be very much outward looking as a portfolio. And finally, everyone will know in this room that as elected members, we represent our residents, and my clear priority is to ensure that residents' voices are heard. It's absolutely key to everything we do, and I want to see residents involved in co-production and shaping services when we're recommissioning services particularly. I will be working very closely with Health Watch. Health Watch are an integral partner on the Health and Wellbeing Board, and I'm ensuring that they have a prime slot on that board so that we can actually hear about the really good work they're doing and hear the residents' voice. All too often that gets lost in rather convoluted language that wraps around some of these health documents, and I think we need to simplify it and really get to the nub of the residents' voice. In brief, challenges have been huge over COVID, again, not exclusive to Buckinghamshire. The report mentions huge disruption to all our teams. People have had to turn their hand to different tasks. Services have been adapted. They've had to flex and deliver differently during COVID. And that's been a huge challenge. And actually, I'd like to put on record how brilliant the staff in the adult social care team and public health team have been over the course of COVID. And we're still in the pandemic, and their work is still extremely demanding and very stressful. I'd like to thank them all. As restrictions ease off, we'll start to see increased demand in many areas, which will be a challenge, not least mental health, which I've mentioned previously, substance misuse, the needs to support clinically extremely vulnerable people who have been shielding, tackle social isolation, and help the people who've been what we call deconditioned after living with the pandemic. So there's a lot of challenges around demand coming through the pipeline. Another huge challenge is the impact on the provider market around care homes. I think Neil MacDonald touched on that earlier, which is very challenging. We're not through that yet, but as a council, we continue to support those providers with our enhanced offer. And finally, workforce challenges have been mentioned and are common to NHS partners as well. Recruitment does remain challenging in some areas, but we've worked very hard to strengthen our workforce, and we've launched the Academy, which was mentioned before, and the Cadet Scheme. And so there are real encouraging signs and, for want of a better word, green shoots coming through from that perspective. So in summary, Chair, there are huge challenges. We have a very good management team, rigorous control of our budgets. We're looking at co-production and hearing the voice of service users as we move forward, and that will remain at the heart of everything we do and one of my key priorities. And I'm very happy to help the HASC in their work programme, which I see you're going to be discussing next. If there's any way we can help with that, I'm happy to do so, and I'm happy to take any questions.
Thank you. I'm just wondering, members, maybe we hear from Jill first and then we'll open the floor up, because I suspect some of this will cross over with what Angela's touched on, and there'll be some common questions for both officer and member. Okay.
Thank you, Chair. I've got very little to add to Angela's very thorough introduction to the report. There are just a couple of points that I want to make. First of all, to reiterate Angela's thanks to every member of staff working in social care roles and public health roles. Their contribution over the past 12 months, not just within the council but also out in the community, has been phenomenal. It really has. And, you know, people have worked without breaks, without taking leave, extra long hours, just to keep people safe. And it's really a privilege to work in the service alongside such dedicated people. Against that background, there are some really notable improvements that we've made to the service over the last couple of years that I just wanted to highlight. We've had a rigorous approach to improving quality and performance across the service. And if you look back in 2019, when we started to do detailed audits of our casework, 75% of those audits came back as inadequate. 2021, 63% are now outstanding or good. So that's a significant shift in the right direction. If you look at our complaints and compliments into the service, the number of complaints has reduced by 32% over the last 12 months. The number of compliments has increased by 30% in the last 12 months. In the first 3 weeks of the pandemic, we made 18,000 calls to vulnerable adults across the county to make sure that they were safe and looked after. We've dealt with an increase in workload in our safeguarding service. We've had 1,774 additional safeguarding inquiries into the service over the past 12 months. So those are just a few of the stats to give you an indication, really, of how phenomenal the teams have been. Not only have they been dealing with the pandemic, but at the same time, very high volumes of work and significant improvements to quality as well. Thank you.
That's very good to hear, and I think we all would like to add our thanks to the teams and all the work they've been doing. Ooh, Mrs McPherson, you're coming back for more.
It's just to add to that it is really encouraging, and actually with the new systems coming in, it's likely that we will be inspected, and we haven't been inspected for quite a long time by the CQC, similar to what Ofsted would be doing with children's services. So it's encouraging actually that we're really on a improvement journey, and will stand us in good stead for when the CQC come in.
I think it's quite phenomenal, really. I mean, when you look at everything that we've looked at over the last 14 months to make those performance improvements, there will always be areas that we can tweak and improve on, but I think the staff really have gone above and beyond. Right, I'm sure members have questions. Sade, I think you're kicking off with the first question.
Thank you very much. Thank you, I should say Councillor McPherson, no Angela. And and thank you to Officer. I remember before I became a councillor, 2013, Angela, and there was another lady, a cabinet member on the ask, and I was representing Health Watch then. And I remember raising issues around housing, and I did participate in a project where we went out with carers as well in the community to see the length of time spent in, visiting, residents, how long for the washing and dressing, the medication. And that to me was a very, very good project. I learned a lot from. And the offshoot of that was on the rates that are paid to carers. And I think COVID has actually brought that to the fore as well. And I remember some of the meetings I attended with the COVID, particularly with Wakeham. And one of the concerns I had was, I always said, yes, acute setting, yes, they're doing so much, we're doing so much, we have a lot of support. But community, where you have carers who go to people's homes, people tend to forget them. And I think it is vital. And my question, therefore, is what are we doing to support, because we're commissioners at the end of the day, what are we doing to support those carers in the community? How are we ensuring that we are paying good rates to the care homes, to the commissioned services, as in the care agencies who are sending carers into people's homes? And also, I wish Neil was here. It's on housing, key worker housing. What are we doing around that? How are we ensuring that we're working with, the acute setting, care homes, to make sure that we have, accommodation, because Buckinghamshire is expensive. My son is over in London, and they can't stay here. And so what are we doing to support people in that area? Thank you.
Well, thanks, Sade. You raised some interesting questions, and actually I was also on that HASC work group when we went out and visited people. So my reference when I was talking about my priorities was around unpaid carers and how we work with carers' bucks to support those people. But your question's around domiciliary care. And I'm sure Jill has got more detail about what we commission. We commission various providers for domiciliary care, and she'll probably have some detail on that. But I know that one of the findings from that piece of work all that time ago was around not just their hourly rate, but the fact that they had to travel in between time and wasn't paid for that. I'm not quite clear what the current situation is on that, so I will defer to Jill on that one. In terms of key worker housing, that's an absolute priority for us, in my view. I mean, the average cost of a house in Buckinghamshire is over £400,000. You only need to do the maths on a basic average salary, and it's just out of reach for new young workers, social workers, nurses, police, recruitment, all of that sort of stuff. So we absolutely need to do something, and I know that our property portfolio holder and our housing portfolio holder are all working together to look at that. We need to assess our needs and see what we can use from some of our estate, in my view, and I know Neil McDonald's doing that as well. So it is an absolute priority.
Thank you.
A good question to put forward to the Housing Scrutiny Committee as well, and they may look at that in a bit more detail. Jill, did you want to add to that?
Thank you. Thanks, Sade. Yes, very good questions. As we know, pay in the care sector is notoriously low nationally, and I think personally that carers are significantly undervalued in terms of their pay. It is a national issue, though, and I know the government is trying hard to do something about it via the national living wage, and we, of course, ensure that all our care providers adhere to the national living wage. There is a bit of a supply and demand issue as well in Buckinghamshire, which does tend to push the wage levels up slightly because we need to pay to get good quality staff. Time will tell in terms of what impact the 3% pay offer for the NHS staff this year has in terms of equivalents being offered to carers as well, but we'll just have to watch that space. There's also an affordability issue because, of course, as soon as the wage levels go up in the provider market, the impact is that the council has to pick up the cost of that, and we do have limited funds at the end of the day. So, yeah, it's a national issue that I completely empathise with.
Robin.
Thank you. In your report, it states you've got 340 contracts. It also states that you've got about 70 something concerns and 44 complaints. You meandered through the fact that they'd gone down, but these are quite serious complaints. And what's the commonality in those complaints? Is there any common themes of them? And how are you addressing them? And how are you using those information to improve outcomes and ensure those complaints don't go forward? Because the report was quite positive, but these are actuals in the report that need to be addressed.
Yeah, you're right, Robin, and we don't take any complaint lightly whatsoever. I mean, it is encouraging that we're seeing a switch round to compliments versus complaints. But yes, in terms of commonality of theme, I think I'm going to ask Jill if there is any thread that links through those. We address each of them in great detail individually, and they come to a board as well where we discuss, the nature of the complaints, if they haven't been addressed in good time, all of that sort of thing, and make sure that we've covered every base on it. But we are working and will continue to work very hard to reduce that number. And as we see our service improving across the board, I'm hoping that they will continue to reduce. I don't think it's realistic to say there will never be any. I think you're always going to get some complaints, but I'll hand over to Jill to see if there's any commonality between them.
Thank you. Yeah, the complaints into adult social care quite often are very complex, as you suggest, Robin. And as Angela said, we get a monthly report into our board where we look in detail at every single complaint. We look at the lessons that we can learn from that complaint, and then we also look at how those can be disseminated across the directorate. So we take an incredibly thorough approach. We treat every single complaint as a learning opportunity and make sure that we act on them. As well as increasing the number of compliments and reducing the number of complaints, I'm also pleased to report that we've
significantly reduced the time it takes to respond to complaints. We've reduced that by on average 20 days, which is a significant improvement as well. Commonality, no, there's no major commonality. They're all very different because they're all very individual, but we certainly look at every single complaint and we learn lessons from them and disseminate them.
Thank you for that. The comments on the care workers, I mean, you will have sat through council and realised that many of our workers, even within the council, aren't paid hugely. There's the pay structure we agreed. So when we talk about increases outside in the care provision, many of our own council staff are very badly paid. So there is a sort of similar price demand for that. So I do think that with the 3%, which seems inadequate, offered the NHS, there will be and should be a balance to the council, and we'll have to look at how we find that money, because that care is too important. We undervalue carers in this country historically. It's not a comment to anybody in the council, but we do undervalue them, and we do need to fund them. But they shouldn't work in poverty looking after people. They really shouldn't.
I think we all agree with you, Robin, and I'm assuming as a service we benchmark against other organisations and providers to make sure that the providers we are working with are offering remuneration at agreed levels. As far as kind of council goes, I mean, that will be something for the scrutiny committee when we look at budget, and you know, we did touch on it at the last council meeting, and I'm sure there'll be plenty of opportunity for you to kind of raise issues about how robust we are in scrutinising salaries for our staff. Do you want to touch on kind of industry standards around pay?
I wasn't going to do that, and I will hand over to Jill to do that, but I just wanted to say that the 3% increase for the NHS staff, if that's approved, will impact the council, because we commission services which are provided by the NHS, and so that will actually have a knock-on effect to us before we even start considering our own staff remuneration.
Jill, I assume we benchmark against other organisations?
We don't benchmark external salaries against other organisations, but we do know from the price that we pay what our services, how our services compare, and actually we tend to pay higher prices for our services. So the implications therefore are that the salaries may also be slightly higher in those providers, and as I said earlier, that's primarily because of supply and demand issues within Buckinghamshire.
Thank you, Jill. Right, Councillor Poll, I've got you next.
Thank you, Chairman. You mentioned about carers being unpaid, Angela. I'm going to suggest that sometimes they're unsupported, but I'm going to caveat that as well, in that many carers are fiercely independent. They and their partner or the person that they're supporting have coped with a lot over many, many years, decades. And they're not looking for support. I can manage is the refrain. And I'm interested to hear about Carers Bucks. I was aware of that, but that's good that was reminded to me. But I'm going to suggest that if a carer is in need, then it's a crisis, because they've done everything they can up to that point. So I'd be interested to learn, now I'm going to dovetail into something else in a minute, about how we handle that. I mean, certainly if I get an inquiry from a resident on another matter, then very often they've done much of the legwork and they've left to me to handle that crisis. But then we as an authority don't deal with queries from members, ward members, as a crisis. We just put that in the list of, oh, here's another query, let's put it in the in tray and see where we go. I was contacted a couple of months ago by a former I'm not going to say service director, I think he was in that position, employee of this authority, with a story about ICP. Now, I may have got this wrong. Is that individual care plan, individual care pathway? Yeah, there's so many acronyms. I'm going to call my version of ICP an individual care pathway, because his story to me was about a young adult with learning disability and quite severe autism who needed to go to hospital, to the A&E department. So he took his younger brother, an adult, as I say, into the hospital, and the hospital were not aware of the severity of his autism. Made him wait until the hubbub in that department became so intense that there was a possibility of a kerfuffle, an outcry. Somebody he mentioned that because this child was based outside of this council area, they had this individual care pathway identifier that they were able to say to the receptionist, we're going to have a crisis if this child can't be seen, this adult can't be seen quickly. That was identified as a purple folder. So getting to my point, carers that are in crisis and adults that need have an individual care pathway or whatever, do we have a means of getting them to the top of the list for our help and support adequately when the crisis hits?
Well, I mean, you ask quite a complex question, and it's about a specific case, and I think we'd need to know even more detail. But what I would say is, firstly, we commission Carers Bucks to provide that support to carers. We don't have a team within the council. We commission them to provide support to carers. With all of this, and as you say, some are fiercely independent, we need to know where the carers are. We probably don't know the full extent of the caring capacity in the council, in the county. And I think that's something that would be very, very useful to know. Quite how we go about that, I'm not sure yet, because this piece of work that I want to start off is going to look at everything we provide, what we know about our caring community, and how best we might be able to support them. And in acute situations like that, how patient information, is it exchanged when people go into A&E? Why wasn't that information at hand when that person was admitted to, I think you said A&E, didn't you? The answer, I don't know that. Jill may know if we've got any more systems about prioritising and ensuring people are kept at the top of the list. But, you know, case studies like that are the sort of thing that I would be very keen to feed into the pieces of work that I want to kick off in the next couple of months. And I'll hand over to Jill for more.
Thank you. Yeah, you're absolutely right. Carers tend to want to manage themselves, and it's only when they reach a crisis that it becomes a really big issue. So the whole purpose of the piece of transformation work that we're doing is to look at ways that we can avoid those crises happening. One of the ways that we do that at the moment is that whenever we've got a client, an adult social care client, we do an individual care assessment on that client, and their carer is also entitled to a carer's assessment. We want to look at how we carry those out and what the options are to offer carers to support them, to enable them to carry out their caring responsibilities. Is that offer good enough at the moment? Are there different things that we can do? Because I'm absolutely convinced that the more we support carers, the more we can enable people to continue to live at home for longer. So that's a really significant piece of work for us. In terms of the case study that you mentioned, the individual case, obviously it's difficult to comment on individual cases, but just generically, I do know that there are mental health specialists from Oxford Mental Health who are actually based in the hospital to deal with exactly that type of scenario. So, you know, they should have been called by the hospital A&E team. So obviously I can't comment any further. We just need to have a look at that individually.
Can I just ask a follow-up, Jill? I mean, you've touched on the fact that we have care and support. What percentage of carers who complete their assessment end up being eligible for help? Do you have an idea?
I couldn't tell you offhand at the moment. I've not got that information with me. You know, the fact that somebody is a carer would entitle them to at least an assessment. But not all carers self-identify, and we don't know all the clients. So, for example, with dementia, we know that only about 60% of people with dementia are actually diagnosed with dementia across the county. So there's 40% out there that are living with dementia. The GPs don't know, we don't know, you know, the carers are caring for them. So, as Angela mentioned, it's really difficult to get hold of that information unless somebody comes forward and wants support.
That might be something we follow up on afterwards, just to kind of understand the level of the number of carers that we assess and the different levels of support that they're entitled to or kind of which services they engage with. And that might be something that the members want to, if we look at carers as a separate piece of work, that we can build those questions into that piece of work. Councillor Gom, your moment has arrived.
Councillor Wassell's going to go after me, so her time will arrive afterwards. So I said earlier on, I'm a primary carer, and I'm lucky because I'm a forward-going person and dig out areas that can help you. I use carers bucks, absolutely brilliant, but there's a stage where it stops, where a carer needs help. Carers go through mental health issues too. They get abuse, they take all sorts. And that's where carers like us need the help. So that's where it needs to move. I'd like to be part of your team that take it forward for private carers, people like me, that are out there, that are strong, that will help and stand up for whoever they care for. They need a bit of help, but it's the abuse side that they take. And it's not just abuse from necessarily the person they look after. It's not necessarily mental abuse that they take from that person. They take abuse from people outside of the family too that understand. And they can also take an awful amount of abuse from people within the family that not necessarily agree of how that person looks after the person they care for, just because of different ways. So it's an area that certainly does need to be looked into. Excuse me that I got a little bit teary-eyed there because it's quite passionate to me. But see, it does need looking into in that sense. So if we can drill down and work on that a bit more, that'd be appreciated. Carers are very independent. They don't necessarily need help in crisis because they try to avoid the crisis to begin with. And that's where places like Carers Bucks is helpful. And what Councillor Mordew mentioned, the Health Watch as well would be fantastic. So it's that we need to gather around. And to be brutally honest, the carers like us, a lot, I'm not, but a lot are scared of the word social services. As soon as you mention that word to them, they go, God. Because part of that abuse comes from outsiders reporting carers, children care, which is rightly so, and adult carers, they report them to social services. And as soon as you hear that word, your hair stands up on your back and you get scared. So we need to break through that side of the stigma that's out there to help with those carers. There are thousands of them, absolutely. So that's one question, well, one point that I'd like to put across. And the other point, do we as a county council scrutinise some of the private care companies, care providers that we use in the area? Again, experience from me was I used one care company to help me along. with my mother at a period through COVID, and only to find that we had to shut the carers down for a short while because of a possible brief of COVID. I paid the company to pay those carers, only to find out, because the carers couldn't come in, only to find out that the care company kept the money and didn't pay the carers. So do we scrutinise that sort of stuff in any way?
Well, I'll just kick off with that, and thank you for making that point. And I can hear the emotion in your voice, and it really, resonated with me. And you're absolutely right about the stigma around social care, and that we need to break through that. I haven't got answers, because that's behaviours and attitudes that change over time. But it's very important to hear people's voices in this, and as we move into the piece of work we're going to do. So I really take that on. In terms of scrutinising providers, yes, I mean, when we spot place people into providers, we would always look at the quality of service they provide, see what the CQC rating on that setting was, and that sort of thing. You're talking about a specific case within that, but yes, our quality control procedure would do that, and we would never place people into a unsatisfactory setting. So we scrutinise the settings and the service provided around that. In terms of this specific case, I can't really go into that, but Jill might like to add something in addition.
Thanks, Phil. And it would be great to have you involved in our discovery work on carers, if you're able to do that, especially given your personal experience. So I'll pass your details on to the team if that's okay. And yeah, as Angela said, we do have quite thorough oversight of private care providers across the county, and there's also the Care Quality Commission that inspects and regulates the regulated part of the market. So that's any part of the market that's giving personal care to people, have to be CQC registered, and they're regularly inspected. And there's also an unregulated part of the market as well, and we do have some oversight of that part of the market too.
I think it's important, if residents or councillors come across issues that individuals or families are having, it's important to pass those details on to the team, because they're constantly assessing providers, and they're also feeding into CQC, and questions can be asked. And as Jill's pointed out, we make those improvements by learning what the issues are, understanding them, and then coming up with solutions. So it's invaluable to have experiences like that shared. Just so that, because I'm conscious we've got several new members, the HAS did undertake an inquiry into support for carers in October 2018, which I imagine Julia was involved with and can remember as an existing member. We have been considering, and it is on the work programme, how we refresh that learning. I think what's important is maybe Liz and I need to sit down with Angela and Jill and understand the piece of work that they're doing with their team. And it comes back to that conversation earlier today about making sure that we haven't got two groups doing the same piece of work. And actually, if you're undertaking that piece of work, it might free us up to undertake on an inquiry on a different subject. But what I would want to see is your piece of work coming back to the HASC for thorough scrutiny, so that we can analyse that and ask questions and make recommendations.
Yeah, and it will be really helpful to see those recommendations from 2018 and see how many of them have been delivered or possibly only part delivered.
Yeah, so I think an action for Liz on holiday, so we shall delegate to Liz, bless her, but we will pull that out, make sure it's circulated to all of the members of the HASC, and also kind of refreshed to the teams, because we'll have new staff who won't be familiar with that particular inquiry, and then it might form the basis of some of the questions and some of the lines of inquiry you're following with the team. So yes, we'll do that. And thank you for sharing, Phil. It's always difficult to share those personal experiences, but it does bring home experiences of our residents. Okay, so I actually have Councillor Fayaz next, so I'm afraid you'll have to be patient for just a minute longer, Julia.
Chair, I had two questions. One actually was asked by Councillor Aldo. I think that it's already been answered. Yeah. The second question is that the deaths in care home during pandemic I'm just asking that what measures we have taken to safeguard the care homes in Buckinghamshire.
Well, yes, sadly, every death in care homes is very, very unfortunate, and there have been numbers of deaths over the pandemic period. We've acted as quickly as possible. Government passported funding to us to support those settings, and we had a range of measures around PPE provision, training for use with PPE, infection control, visiting, all sorts, a whole package of measures that we shared with our care providers, and we would contact them on a very regular basis to see if we could offer additional help. So, you know, there's been a huge amount of work done on that, and I'm happy to provide the committee with all the measures that we have taken to support our care providers. But you know, sadly, if the infection got into that community with very frail elderly people in, before obviously the vaccination programme was rolled out, it was very likely to have the worst sort of impact, and in some cases it did. And I suppose at the beginning of the first lockdowns there were issues around staff not working in one setting exclusively, so you would have staff going from one care home to another, which wasn't as helpful as it might have been. So, you know, lessons were learned very quickly, and I think as a council we worked extremely hard to develop the offer for care providers and put that in place, and passport funding to support them as quickly as we could. But Jill might want to add more to that.
If I could just add one thing, Chairman, just to remind the committee that also the government has announced mandatory vaccinations for care home staff from October, and that also includes any staff visiting care homes. So any social care staff, for example, or primary care, GPs, would also need to be vaccinated, and that's another sort of measure, if you like, to try and protect and put a wall of protection around care home and vulnerable residents.
Thank you, Jill. Julia.
Thank you, Chairman. Well, it was so great to see you both today. You came in and, you know, you seemed to be in good state of morale and quite upbeat, and, you know, it was really refreshing to see you both. And a lot of the thoughts and worries and concerns I've had as a social worker, with everything that's happened with the pandemic, where to me the landscape is entirely changed. People say we can park COVID now, let's just go back to, you know, it has fundamentally changed in so many ways, whether it's digital stuff or the loss and bereavement people have had along COVID. The landscape to me has changed, and, you know, I believe that you two women, you know, understand that whole, you know, the whole, you know, have the strategic view of everything that's happened. I mean, I would agree that social workers and social care workers must be praised, because we hear a lot about the NHS all the time. We love the NHS and we clap for the NHS. And I did make sure I put a banner up, adult social care staff, actually right on the London Road A40. So you came in quite upbeat, I thought, with these priorities. And the first one, well, that's challenging the parity of esteem. Of course, mental health and physical health needs to have parity of esteem. But I was reading an article saying we were such a long way from it. There were so many barriers, financial barriers, treatment barriers, high mortality rate in mental health barriers, that I was thinking, well, are we ever going to see that? But you coming in and saying it's a priority, you know, it reinvigorates me to think about it again. Is it possible? Is it just an aspiration? Other issues you've picked up, particularly carers. I was very worried to see carers of people with dementia at home during the pandemic. They couldn't go out to day services. The day services had to close down. And I do think there are gaps around in neighbourhoods or, you know, in areas that I'm looking into in Wickham as the chair, the wellbeing, you know, community board thing. I do feel there's gaps and lack of access for whatever reason to day services. But, you know, I think your priority is exciting. I mean, it's the implementation of these things on top of everything else, isn't it? So, you know, do both of you have some kind of real aspiration for implementation? Perhaps of one thing you could tell us about that you're going to be implementing.
Well, thanks for that, and I think, you know, we have to go forward, stride forward positively from this really, you know, life-changing situation, and it will change the way services are delivered.
Yeah.
Sadly, yes, for a short period we had to close day services. They're open again now. We're going to look at ways we can deliver services within the community. All members around this room are absolutely vital in feeding in information where there may be gaps in the service to the service area, working on community boards at local level, using some of the funding that's priority funding in community boards for delivering those services. So I mentioned that before, and I think it's really, really important. If you're asking me to single one thing out, I can't, because we've got a large transformation programme. We've got dedicated staff working on quite a few work streams. The two I've picked out are my personal priorities as a cabinet member, which is around mental health and around carers, and we've discussed carers at some length. Mental health is huge. We probably need to sharpen our focus on specific areas of it. I think for me, there's my interest is particularly around how we deliver in the community, how we help people, and many people at quite a low level of anxiety and mental health get through that with community interventions, befriending services, that sort of thing, and ideally more face-to-face as we move out of the pandemic. So that's my particular area of interest, and I know the team are working on this, so I wouldn't say there's only one thing we can do because we're so overburdened. Yes, we're stretched, but we have an absolute focus on this sort of transformation work, and we've been spinning the plates all the way through the pandemic, delivering business as usual whilst addressing the COVID crisis. So Jill might like to add more.
Very briefly, just to reassure you, Julia, we've got a bit of a track record of delivering our transformation objectives in adults and health. We've delivered now a 3-year phase 1 of Better Lives, which has improved outcomes, as we've demonstrated, and saved £10 million. So we are just scoping up phase 2 of that programme with the priorities that Angela has given us. So if you look back at our track record, we have delivered. We've also got really good governance around the programme. We have a monthly transformation board that Angela and I sit on and I chair, and that we hold our service directors and heads of service to account for delivering their objectives.
Thanks, Jill. I mean, just touching on that, obviously phase 1 of the Better Lives strategy ran from 2018 to 2021. Appreciate it's been a heck of a year. And in an ideal world, we would have been starting to do the scoping work for phase 2 so that it would slot in seamlessly. Especially for new members, maybe you can tell us about the time frame of that scoping work and when, you know, the new period, this phase 2, when it will run until. And also, I did notice that phase 2 is going to focus on support to carers and living with dementia, as you've outlined. There were other areas of focus in phase 1, mental health, social isolation, and preparing for adulthood in particular. Maybe you can signpost us to what work's been done specifically on preparing for adulthood, because I'm not personally aware of any, and I think it would be good. We've had some discussion today about how this group interacts with the Children's Scrutiny Committee, and CAM services, and Councillor Poll's asking about when do you become an adult and how do you transition from children's services through. It's all very complicated. So I was wondering, what made you choose support to carers and living with dementia in particular, especially as you, Angela, have just highlighted that mental health is a huge area that we could hone in on a couple of parts of that.
Yeah, I mean, there are a lot more programmes as part of the Better Lives, and really it was my personal commitment to the carers aspect and the mental health subject that I wanted to highlight to committee, but that by no means makes up the whole range of the transformation programme. I believe we're refreshing the Better Lives strategy as we speak, and I'm looking at Jill for that. In terms of preparing for adulthood and when do you become an adult, I don't know, because I don't really feel I have yet. But quite seriously, we've done a huge amount of work on that, and that's all about making that, as I said earlier, that seamless transition so that children at 18 don't sort of fall off a cliff edge as they transition into adult services. And I'm sure the team can send through the work that we've done to date. It's got performance monitoring against it and all sorts of stuff. There's a huge amount that's been done, and we've been working with children's services on that. So if that's an area you want to look at, that would be
I think that
fine.
would be really useful for members, because it will give you a kind of baseline, and then when we see the refresh of phase 2 coming through, it will inform members, I think, and help to kind of frame any scrutiny questions around development of phase 2. Jill, were you going to come in on something?
Yeah, just to reassure you that phase 2, there are a lot more programmes in than just mental health and carers in there, and they're all chosen on the basis of evidence. So we do an analysis of the service, and we look at where we think there are things that we can improve based on the evidence that we've got. So those are the things coming through, and learning disabilities is in there again for phase 2. There's a lot more we can do. We know with housing and learning disabilities, for example. So it's a much bigger programme than the few priorities that Angela mentioned earlier. And also on PFA, that particular project was a really good example of where we did a lot of co-production as well. So I think if it did come back here, you'd be quite interested in some of the methodologies that we used.
Okay, thank you. Any other questions, Councillor Stutchbury?
Yeah, thank you very much. It's been a long debate. The report that you presented references processes and package of care for people. Can we at some point have an early sight of that to understand it, not to discuss it today? You also reports mentions restructuring and key. So what were the key benefits of restructuring, and what were the outcomes of that? And is there any service gaps that it filled, or did it create new service gaps after restructuring? But I think the other question, we really need to have that back again, not now. I don't think, you know, the asking about the reference report refers to new procedures. I think we need to see those before we discuss them, not just do it now. Does that help? If it doesn't help, I'll do it again.
Is that the procurement package? Yeah, of care services.
As I said, I don't discuss it, just see it. But the other thing is a question really about, you said you've had a change in service and whatever. I think I need to understand what that did and how it worked and whatever.
We can send more detail through. It's early days. This has been the first restructure, I think, in, Jill will correct me if I'm wrong, about 15 years for the service. It was well overdue. One of the things it's done is reallocated caseloads much more effectively, so that some people were very, very overloaded with casework and others weren't as much so. So it's smoothed out that and made the teams more easily managed, really, in terms of their casework load. And it's enabled us to put people in the right places, occupational therapists, for example. So it's early days, we've only just done it. People are slotting into new jobs, but actually I would think in 3 to 6 months we'd be more than happy to bring a report back to you and tell you how we're working to improve the service and how effective it's been, and if there are any gaps that are still remaining, because as I said earlier, recruitment isn't easy, and particularly qualified staff at a more senior level are fiercely competed for in the South East particularly.
Thank you very much for that, Councillor Pheasant. As you know, I question you all the while. I thought I'd stick on your report rather than my thoughts today. Thank you.
Yeah, we can certainly look 3 to 6 months' time, kind of next year, look at a HAS meeting next year where we get a bit of feedback on that. I think as well, what might be useful for members, you referenced the fact that we haven't had a CQC inspection for some time. It might be, I don't know, kind of time frames of when you think that will commence. I don't know if it's like Ofsted, you get 2 days notice and everyone scrabbles around to clear their diaries, or if you get more advance notice. But I think, again, because we've got a lot of new members, kind of report from the last inspection, so that we've got a bit of background there to kind of then have a reference point when we see the new inspection report.
Yeah, and I think this is a totally new regime, so I really don't know when there was a last inspection. I don't think there was one.
It's not been agreed nationally yet, the new regime, so it's still a long way off. We don't know what it's going to look like. It's likely to be a partnership type inspection rather than an inspection of adult social care. So it's very unknown at this stage. And the last inspection was probably more than, I think it was definitely more than 10 years ago. So it would be completely irrelevant really now in terms
Okay,
of
well,
the
that's good to know.
services.
I mean, that's informed our learning. We'll all be learning together, it sounds like. Are there any more questions? No, not from the floor. I mean, one thing I picked up on, which I was glad to see, because we're wrestling with it as a town council at the moment, employee assistance programme, and you've said you've done a lot of work to promote that to employees through a very intense period. I mean, we've touched on mental health and the ramifications of what's happened over the last 16 months or so. Are you going to continue to promote that, and is that a programme that we remain dedicated to? Because quite often the fallout of these big events happens much further down the line.
Yeah, I mean, I would say we absolutely have to, because we haven't moved out of the pandemic yet. I mean, who knows what's going to happen over autumn, winter. There could be a resurgence. Let's hope not, as the vaccination programme kicks in. But, you know, ways of working are going to change. So we will need to keep supporting our employees with, there's no doubt that people have been affected on a mental health basis across the board. It's not just adult social care, but all our services. So we will need to keep that going. We will need to understand from staff what they need to enable them to work flexibly. And yeah, I think it's very important we keep that going. But Jill, again, you may know more.
It's a corporate scheme that's available to all staff and very much valued and supported.
Okay, thank you. Oh, Councillor Heap sneaking in there. Last question.
Thank you, Chair. Can I just ask you about the new hospital discharge initiatives that were introduced during the pandemic? I was interested just to know whether those were designed in collaboration with the Health Trust or if they were imposed, and also what is your experience with those schemes? What has been the impact and the effect on, for instance, the waiting time for assessments once patients have been discharged to home or a home? Yeah, so how's that going?
That's a hugely detailed question, but I'm going to hand over to Jill on
I think
that discharge to assess.
A whole meeting on that particular question, but I'll try and be very succinct. It was a new national system that was imposed nationally by National Health England on all local authorities during the pandemic. And National Health England also provided funding to enable people to be discharged from hospital very quickly, and they funded their care and support in the community for the first 6 weeks of that discharge to enable the assessment to take place out of hospital rather than in hospital, so that it freed up hospital beds. That funding has now been reduced to 4 weeks and is due to end at the end of September. It did have an impact, obviously, on hospital flow, and it was very valuable during the pandemic. The government are looking to continue it now, but there's the big conundrum about who's going to pay for it.
Yes, we'll watch that one with interest. Okay, I don't think there are any other questions, but thank you for coming and sharing a lot of information with us today. And there's some good key points that we'll pick up at some point in the future. Thank you very much. Yes, you're welcome to run away. I'm sure you're both very busy and it's lunchtime. So I will move swiftly through the last item, which is the work programme. Liz has already sent an email out to members. We're suggesting that we have a kind of small workshop. We may even be able to do it online, which will make it easier for people attending. We have got, and I'll make sure Liz recirculates it, has sent round, we've got 2 pages of items. Obviously, we need to think about the next meeting, because item 11 is that the next meeting will be on Thursday, 30th of September. I think just listening to what's been discussed today, I think really the ICS and the development of the ICP continues to be a concern, and I hope that by September we might even have some detailed plans around how all of the BOB elements are developing, and it certainly seems as though we may have some new strategies coming forward from the NHS Trust. So Liz and I will monitor that over the next few weeks and see if that's relevant to bring back to the September meeting. And again, I think primary care networks has been an ongoing concern for the last 2-3 years. So I think it might be useful to revisit that in September to kind of impart quite a bit of knowledge and information prior to the meeting to new members, but also to get that conversation moving, because it does link in to digital strategies, how we engage with our residents, whether they're accessing GP appointments, and also the knock-on effect for the trust over the winter period, which segues neatly into a third topic, which might be the winter plan. We'll be kind of moving well into it, but by then hopefully the Health and Wellbeing Board will have assessed initial discussions over the winter plan, and we'll have much firmer plans coming through from the Trust. So I think that will give us quite a meaty agenda for September if members are happy with that. Councillor Pole?
Thank you, Chairman. I'm just having 2 important thoughts. Regarding, you mentioned about the BOB ICS scrutiny panel, overview panel, whichever they call it, and that there are 6 places on there for Buckinghamshire. Question 1 is, do they need to be all councillors? Is it the sort of thing that non-elected, i.e. officers, could attend? Because I think one of the most important things, and being a new member on this committee now, is the amount of time it takes to pick up and get running. We can do all the reading of what's gone on before, but until we get into the rhythm of the meetings here, and more importantly the BOB ICS, because I think there's a lot of questions that scrutineers will need to be on top of. So that was the first point. And the second one was about the key worker housing. I know we've transposed our scrutiny managers from the varying committees. So would it be appropriate for our scrutiny manager to mention or to shoehorn in that item to the Infrastructure, Housing and Growth Select Committee?
Yes, so I can certainly pick that up and speak to the chair of that committee. And, we are all councillors. We are all welcome to pose questions to other scrutiny committees. Any member of the council can, as can any member of the public. So, Sade, you asked a very good question about housing for workers, and I think that's important. So I would urge all members to take matters forward to other committees where it's pertinent. I can make a point of flagging it with the chair of the committee. It's up to that committee to determine what their priorities are and where that question fits into the work programme, but can certainly flag it with the chair, and that's something, again, Liz and I can pick up next week. And Kelly manages that officer team. Well, there you are. We have a vice chairman who sits on that committee, so I hope to see it on an agenda very soon.
I may forget, but I wonder if there was a formal way of doing that. And as we have the scrutiny manager here, then is that appropriate to have that formally done?
Yeah,
But
I
more
will make sure
importantly-
it's passed forward, yeah. So,
more
and at any
importantly-
point, if there are other issues that members want to push forward to other committees or seek more information, and you don't have to do it within this committee, you can pop emails through to Liz and I constantly, and we will pick issues up. And then it's a question of whether it needs to be scrutinised at HASC or whether there are other pathways to actually have issues addressed. Sorry, Robin, just before you come in, the other question about the Bob Joint HOS committee. So obviously we have representation. So the 7 members of Oxfordshire, 6 from Buckinghamshire and 6 from West Berkshire, they are elected members. We envisage, initial discussions, we envisage that committee will work in very much the same manner as this. So I believe there is provision to co-opt a member of Health Watch, and there are discussions going on in Health Watch because obviously they have different representatives across the different areas. So that's something for them to decide how to fine tune, and that will be part of the first discussion. Who will represent Health Watch and attend those regular meetings. And we're only talking about 2 or 3 a year until we're up to speed, until we understand how much there is to scrutinise. There will also be, as we've had today, depending on what is on the agenda and what the issues are, Dr. Kent, I believe, would probably be a very regular attendee at all those meetings, but we will pull in those experts, be they, and there's been some discussion, there will be key pieces of work that will need to be scrutinised, and we will need, because it's medical based as well, we will need specialist advice. So for instance, if there was discussion over a cardiac unit and where it should be placed and where it's best placed to serve 3 counties, then obviously there will be cardiac specialists and other property specialists that would come in and advise that committee. So at the moment, until we get up and running and have the first meeting or 2, and like, as you say about this committee, get into the rhythm of it, we envisage it working in a very similar way where we do pull on experts and we do call people in to present reports, answer questions and interact with the committee in a variety of ways, and that will be across many stakeholders. So does that help? Yeah, okay. Robin, have you got a quick one? Because Mo's running out the door. Thank you, Mo.
Just to support Chris, really, and I think he's right to get that on there. The other thing we need to do is, again, understanding the disposal of the assets, because we could, with wrong decisions, dispose of assets for commercial reasons, which could be used for internal commercial reasons better, because the two decisions have to be in sync. You know, if we have to dispose of an asset because we have to dispose of an asset because we have to raise revenue, it shouldn't prejudice, as Councillor Pole says, the progression of our key worker houses. We've got to make sure that those, because you buying them back, if you got rid of them, it's very expensive at the point you've got that property in your hands. So I think those 2 things need to be recommended to be looked at together, just to make sure that the Cabinet member doesn't go off getting rid of property to raise the money for the budget, which he has to do. And then we find that 10 years down the line, we haven't got the property or the space to do the property because we sold it to somebody else who's now made a lovely lot of money developing it because they can do commercially. 2 things aren't contradictory, but I think to support Chris completely, he's absolutely right.
Yeah, so I think, I mean, if you're talking about property and assets in terms of Buckinghamshire as a county, then yes, I mean, that's, well, if there is disposal of an asset that reduces a service for residents, that would probably be something for us to scrutinise. If there is a more general discussion around delivery of housing and use of council assets within that, then I think that is probably for other committees. We're concerned with health and adult social care services and those outcomes for residents. And I would hope that any decision around any asset to keep or to dispose would be made with a full and robust report that looks at numerous factors. But I'm sure you will keep a very close eye on that, Robin. So,
Sure, you're watching everything, yeah.
We know. Well, all that remains is thank you very much, all of you, for attending. It's very nice to see you all in person. And Liz and I will pick up various matters next week when she's back from her vacation, and we'll get things moving. And I think the most important thing is to have that workshop around the work programme and to really, start looking at some inquiries and some task and finish groups for the year ahead. But thank you very much, and safe journeys, and take care.